Good morning, honorable members. We'll be starting our meeting in the next 30 seconds. Honorable members, good morning on this third day of March in our portfolio meeting that starts now. Listening to the presentations of provinces, and today listening to the last province being the Free State Department of Health. I welcome you and thank you for your logging into this meeting. I also noticed that there's been a login from the Department of Health in the Free State. I therefore last night requested Ms. Machalamba to deal with the item of the minutes later after their presentation that they've logged in. Safe to say, I can now confirm that we will have another portfolio committee meeting, honorable members, this coming Friday at 9 o'clock. I request you to diarize that. We will be meeting with the minister, giving us an update. As we had resolved, we would want him not to take the Wednesday slots, but take whatever is available on him fortnightly, so that we don't miss out to get updates, but also we have Wednesday still available to do other portfolio committee work. Thank you very much. May I then hand over to Ms. Machalamba to indicate the attendance and apologies if received.
Good morning and thank you, Chair. Present is Dr. Dlomo, Mr. Munyai, Ms. Gela, Mr. Sokacha, Ms. Ishmael, Dr. Jacobs, Ms. Chirwa, Ms. Hlengwa, Dr. Tembe Kwayo. I've received an apology from Mr. Van Staden. He's attending a constituency meeting, and Mr. Imam Sheikh is attending a meeting with the Appropriations Committee. Thank you, Chair.
Okay, with that, honorable members, I will then
Chairperson.
And with Honorable Ismail first. She had her hand up. Honorable Ismail.
Thank you, Chair. I've just spoken to Sibiwe. She's having some network problems, and Lindy will join shortly.
Honorable Dr. Jacobs.
Chairperson, I have to attend to something very urgently. I'm going to be joining on my phone, but there might be a time that I might be cut off and I will rejoin again, if you note that. Thank you, Chair.
Okay, thank you very much for that information. That Honorable Kwahube, Honorable Wilson will be joining shortly, still having some connection challenges. MEC Thu, welcome. Thank you very much from the Free State. I'll give you an opportunity to show your face and greet us and introduce your delegation, and therefore take it from there. You present, or whoever you delegate to present, we'll take it from you. Honorable MEC.
Good morning, Honorable Chairperson and honorable members of the committee. My name is Dr. David Matau. I am not the MEC. It would seem the MEC is struggling with connection, but we are trying to sort that out as she's attending offsite. Offsite, I mean, offsite from the department. I think, oh, there she is. She's coming in. Thank you. MEC, over to you. The chairperson was looking for you. We indicate that you have challenges with connection.
Welcome, MEC. We are giving it to you now to indicate the delegation that is with you and what you are presenting to us. The HOD was about to start, but then he noticed that you are logging in. So we will have to be giving you the first bite in this presentation. Take over, MEC.
Thank you, Chairperson. Chairperson, I would request the HOD to say who we are with. My name is Montentu. I'm the MEC for Free State. I will request the HOD to introduce the delegation that comes from the department, and then from there I can give the political overview. He will then continue with our presentations to the honorable members.
Thank you very much. Through you, Honorable Chairperson. I've already introduced myself. My name is Dr. David Bikuzo-Mutau. I'm the head responsible for health in the Free State Province. Chairperson, I'm with a large contingent of my team from the department side. We have the DDGs, the DDG Clinical Health Services that is with us, Dr. Mlokome. I'm not sure if he has joined yet, but he's supposed to be part of the team. We have a team from the, which we call surveillance team, led by Dr. Semi Mukwena and Dr. Mutong. These are our public health specialists that were in the forefront in terms of strategies and as we responded to COVID. We also have, and we did this deliberately, we invited the district managers because our understanding and posture is that this COVID-19 pandemic is, and healthcare services in general are happening at the district level, and therefore it would be important that they also get invited, not only to get a feel of how things are run in Parliament, but also to understand where honorable members are coming from in terms of the deliberations. We also have the Chief Director District Health Services who's supposed to be with us, Dr. Grace London. We have the staff from the Office of the MEC, led by the head of office in that office, Mr. Mkotedi, and we also have the parliamentary liaison officer, Melindi Mkopan. So, Chairperson, that is the team that is going to be engaging with yourselves. Or I had forgotten Mr. Mzonakele Figizolo, who is the chief director. I mean the DDG responsible for corporate services. We also have Mr. Oliphant, who is responsible for the strategic planning division. We have Papima Rohani as the advisor to the MEC. And then we have Mayor Priscilla Munyobo, who is part of the surveillance team that is working with Dr. Mutong, as I've indicated earlier. I think, Chairperson, so far, these are the people that are currently on the call, and I will, if need be, talk to others that would have joined a little later. Thank you, Chairperson.
Okay. Before the MEC, thank you. Before the MEC makes her opening remarks and political comments, just to indicate that there's been 3 other members who have since joined us. Were delayed is Honorable Tseke, Honorable Wilson. Honorable Kwahube has not logged in as yet. 2 have just joined. Oh, yeah, Honorable Harvard, Dr. Harvard. There's the 3rd one who has logged in, who was also not picked up initially. Thank you. Back to you, MEC.
Honorable Chair, for the opportunity. And let us appreciate, as the Department of Health Free State, the invite that we had to come and talk to the honorable members in the portfolio committee. I would just make an overview, Chair, like I said, and the presentation would be done by the HOD, then would be get support from the team that we are with. Let us start that we also as Free State saw our first patient of COVID-19 in March, and since then I think that was the start of the bad things that happened, because when it started at the church. Many people got infected. But what we got right was to follow the principles of the public health of ensuring that we trace all the contacts and isolate those that needed to be isolated, and also admit those that needed to be admitted. The lesson that we learned then, in fact, what we planned was the fact that because these people are then bringing a pressure and additional people to take care of to the department, because we as any other health department, we have been having a chronic shortage of staff in our facilities, but here is the extra work that needed to be done. Our teams that were going to work in the communities that would be leading the professional nurses that would lead our community healthcare workers, we had to take them from our own facilities to make up those teams that would be going out in tracing the contacts and also swabbing those patients, training them on swabbing the patients, and then making sure that we do there's no gap, we do our work as it should, and we make sure that we close this issue of the spread of the virus as quickly as possible. So that also created more pressure on our existing facilities. But and even the admissions, because now we had just prepared about 39 beds when we began at Pelonomi, and we had not prepared as many beds as possible. In other districts, we've just requested to the hospital to prepare 5 beds each, because we did not know how this would hit us. That then showed us that we needed to increase beds in our facilities. That is why we took a conscious decision that indeed we would work on preparing the field hospital. But what is important for us would be to improve our existing facilities, in which we know that even beyond COVID, we'll be able to use those facilities for other health services. So our budget too was, most of our budget was diverted at working with the fight against COVID-19. So our other facilities, we then identified facilities where we were going to increase the beds, improve the infrastructure, increase the beds. And luckily we got an extra money for us to employ the extra staff, but we had to employ them only on contractual basis, because we were not guaranteed that that money would then be with the budget all the time. So we couldn't even wait for the money to be allocated. We used our existing budget to ensure that at the time we employ people on contractual basis, so that we are able to deal with the COVID-19, because it could not wait for us to get the allocation. It was already there, and we had to act at that time. But the unfortunate situation is the fact that as time goes on, the department experienced a budget cut, as we had seen. That budget cut then created a pressure on the department, but we continued, and we were able to do the work as we could. But even at the time when we wanted to increase, because our partner, we were working with partners. Red Cross was one of the people that came and helped us increase the number of community health workers that were working with us. But there was a time when Red Cross didn't have money, and the department was forced to absorb those community healthcare workers that were contracted to Red Cross, because we needed them. At the time, our teams had been beefed up by them, and we couldn't lose them. We had to make sure that we provide for them so that the teams can work effectively and optimally, so that we don't lose anyone. Like I said, indeed, we concentrated on ensuring that we increased the beds within the facilities, and I think that helped us a lot. we then took the advice that we had to also have a field hospital. But fortunately for Free State, that field hospital, we towards the end of the first wave of COVID-19, we couldn't even use that field hospital. We had then to propose that we decommission that field hospital, because most of our hospitals now, our facilities, had enough beds where we could admit, even if the wave went extremely high, we could admit within our own facilities. So we presented that to EXCO, and that was agreed. So we decommissioned our field hospital. We had extra beds at universities, underground packing at Pilinomi, at Bongani Hospital, because we made sure that we identified where the space in all the districts, all our districts had extra beds added, so we were able to deal with the pandemic. And we worked together with our sister department, the Department of Distia, where they then provided their own holiday resorts, where we used those as part of where we quarantined the people. Our PUIs were quarantined there, and the people that really did not have severe symptoms, that just needed to be isolated without them being admitted, were isolated there. And all our hospitals, we never experienced any problems when it comes to the issues of oxygen. We were ready with that, the oxygen was there. Our staff members at the beginning, because of the fear that everybody had of this illness, they really were, some of them were reluctant to work in the COVID. But then we made sure that we deal with the issue of psychosocial. We created a team, a provincial team, that dealt with the psychosocial problems of our health workers, and we made sure that we train our people so that they are able to take care of these patients. And as we work, indeed, some of our people, our workers got infected. But when you check, most of the people the workers that got infected were not the workers that worked in COVID dedicated facilities, because those ones were well trained. They knew how to take care of themselves and also take care of the patients. I think that is where we got it right as the province. In fact, we did not just train those that worked in the COVID dedicated wards. Every worker, every health worker that worked in our facilities was trained. We even trained our own EMS personnel so that when they go, say, to get a patient that is infected, they know what they should. At the beginning, we had identified ambulances that would deal with then deal with the COVID patients. But then, as time goes on, we learned the fact that sometimes people would call the ambulance without knowing whether the person is positive or not. And then the people would just go thinking it's just an ordinary patient. We then decided to say every ambulance, every patient should be treated as COVID-19. And people, when they come to our facilities, prior to them being admitted, they should all be tested. One of the things that we did was the fact that even people that died at home with any respiratory illnesses should also be tested. So I think that is how we then managed this war, as we were led by the provincial command council, and that was led by the premier. And in the district, because we used the district approach, they were led by the district mayors. We worked together with the district managers, the district mayors. And like I said, we worked with our sister departments in social development and also a Department of Education, where we work together with them, taking care of the learners and also the teachers. That is still continuing even up to now. And I think that working togetherness, and also the report of that we get on daily, that we get daily, that is the surveillance report that is then done by the provincial team that is led by the HOD and the DDG that works together and make sure that the information in COVID is collated on daily basis. So we are able to we identify any problems or gaps quickly, so that we are able to deal with them. Even the challenges that we have, we are able to deal with them. And we appreciate the fact that our two universities, that the Central University of Technology and University of Free State, came to party as well and worked with the department in the fight against the COVID-19. I would say, and not just them, even the Right to Care and other partners came helped us. So Even though we had limited funds and budget, our partners helped us a lot. And those workers that we contracted in a 1-year contract, because COVID-19 is still over, we are going to need those people. And our wish as the department would be to absorb those patients, those that personnel that we have, because they have indeed beefed up the shortage of staff that we have always had as the department due to the lack of, the mega budget that we are having as the department. I would end there, Chairperson, and allow the HOD to continue with the presentation that has been prepared for honorable members. Thank you.
You can continue, Head of Department.
Thank you very much, Honorable Chairperson, and thank you, MEC, for the outline of some of the challenges that the department experienced during COVID. Chairperson, if you allow, we had prepared 2 presentations. The first one is just to share with the committee in terms of some of the challenges that we wanted to highlight, but also perhaps demonstrate as to how we are going to try and deal with the aftermath of the COVID-19 pandemic. Now, I will start with the first one, Chairperson, and I hope you can see my slide.
Yes, sir.
Thank you. For the purpose of challenges of bandwidth, Chairperson, I'm also going to request your indulgence in terms of me switching off my video. And then at the time when we do, when you ask questions, we will then switch on the video if you allow. Now, this presentation was based on the fact that COVID came at a time when nobody expected it. And I think the MEC has adequately ventilated, the issues when it started. But I must indicate that as we responded to this COVID, we relied heavily on the National Department of Health through structures that they had established, one of which was the modeling consortium that guided us in terms of what preparations and to the extent of the number of beds that the province needs to have. You'd remember that around the 6th of May, we were informed about the modeling or the forecasting in terms of what the provinces need to have in terms of capacity. And there were 2, the optimistic as well as the pessimistic view or forecast, as it were. And the first one was indicating that we needed to have at least around 3,886 ICU beds in the province. And we also needed to, my apologies, non-ICU beds. And we also needed to have about 1,080 as at the 1st of August 2020 in terms of your non-ICU beds. Now, we started preparing according to that. And what was also then indicated subsequently around the 20th of May was that in total, the province needs to have about 4,747 oxygenated beds. And then it was then indicated to us later that we also need to make sure that we have about 1,591 beds for critical beds, Chairperson. Now, in total, the number of beds that we needed to establish.
Excuse me, Chairperson, can we see the slides of the presentation, please? Because I'm only stuck with the introductory first slide. Yeah. Sorry for that.
My apologies, Chairperson. I was just trying to give the background.
Your background must also be reflected there, Dr. Mutau. Your background is written there. Go through it.
Thank you very much. Thank you. My apologies, honorable member. So that being said, we needed to make sure that we establish those number of beds. Now, the MEC has already spoken to the part of the background that I was trying to amplify. And we then agreed as a department that firstly, we needed to form a structure which was going to look at governance issues And that was implemented, and we agreed that we need to follow a district-based response model, which we also implemented. And of course, our reasoning at the time was simple, that all this is happening at the district level, so we need to strengthen our districts, because that is where healthcare services are really taking place. At head office, there's nothing much that is happening, so we need to strengthen the district and the sub-district level. So it would then mean that in terms of case finding and investigation and contact tracing, as well as monitoring thereof, the district has to be empowered in that regard. Now, we then developed an organogram for the district in terms of case management and how that is going to unfold. And that slide is just depicting that. Of course, it would not have been possible for us to then deal with the response without developing a strategy. And our strategy was also clear and practical, in that we concentrated on the 4 pillars, which is evidence-driven as a pillar, but the strategies and implementation thereof was also important. And we also looked at the organizational structure and the data management. I'm just running through this, Chairperson, because there's also another presentation that I must present immediately after this one. Now, in terms of the challenges, really, as the MEC has said, one of the biggest challenges that we experienced in the province is the fact that in terms of our professionals, we had to take our healthcare workers from their normal duties and convert them to the soldiers that would respond to COVID. Now, as we did that, and the days and weeks and months went by, we then realized that there was a COVID fatigue, which was creeping, and it was coming at a time when we also were experiencing shortages of staff. And of course, that also had a ripple effect in terms of the poor capacity in terms of responding when we wanted to trace and our cases, and we experienced some backlogs. And then we also had a problem in as far as poor skills for clinical management of patients. We would appreciate that this was a new pandemic that we did not know anything of. In fact, I often said what we know about this pandemic is what we don't know. And there, of course, were challenges in as far as the lack of integrated information system with the ever-changing technology. But there was also poor compliance in as far as the regulations are concerned. If we go to the next slide, and I think this slide is really what the MEC has spoken to, but I want to slightly amplify it in saying that when we first went into lockdown level 5, that affected the healthcare services, as reconfiguration of services was necessary in order to maintain responses that's leading to increase in the number of COVID-19 and other diseases. Now, we also experienced the delayed or waiting times in terms of surgeries, but also the fact that we had sort of reduced the services that we were offering in our hospitals also came in as a problem. There was also poor performance on key strategic programs like your HIV and AIDS and TB, as well as the maternal and child health. This was further compounded by the fact that we had our budgets cut, and of course the fact that the lockdown level 5 and 4, where there was no movement at all, it delayed our infrastructure rollout plans in terms of what we had. If you go to the next slide, this is where I'm trying to demonstrate in terms of just one program, which is a policy imperative, where on the 90-90-90 strategy that the department, like any other department out there, needed to implement. You would see that we are well on track until such time that COVID came in, and we are unable to perform in as far as the first 90 is concerned. But all indications are that we were on track, and the reasons for that would be the reduced PHC headcount and non-functionality of of the adherence clubs during the lockdown level 5. And of course, the next one would be the fact that people could not move around. That also made a bit difficult for us to achieve in as far as that is concerned. This is just another demonstration in terms of PHC utilization under 5 years, which I've already talked to, and we also developed an action plan in terms of how we're going to catch up, or as I indicated earlier, in terms of the dealing with the aftermath. And this slide is ushering us into that. Now, coming out of lockdown, we needed to look at what is it that we're going to do first and how we're going to do that. And considerations needed to be made in as far as the rationale for decanting services. And this slide is really talking to that in terms of the services that we needed to usher back in. And the second one is the time delay in terms of the number of cases that needed to be operated on. Now, we had, of course, benchmarked and looked at various countries as to what is happening. And one of the things that we came out with was that any change in lockdown measures has a 3 to 4 weeks delay period till the effect is exerted. And this was based on multiple studies in Germany and the United Kingdom. Therefore, no change in operation referral patterns occurs 4 weeks after decrease in the lockdown capabilities. For this reason, in the healthcare setting, we should stay at level 5 capacity for at least the next 3 to 4 weeks until an assessment can be made of an altered transmission dynamics and infection rate as the community transitions to level 4. Now, the issue of testing is also important in terms of our healthcare workers. And of course, lastly, the issue of PPEs is going to be quite central in terms of when we increase now our theater times, as well as the availability of theaters and the operations are back on swing in as far as making sure that we catch up with the backlogs. Of course, the issues related to the ICU and ward bed capacity as well, we did look into that. Now, in conclusion, we are saying the solid provincial multidisciplinary team is the backbone of an effective public healthcare response. And of course, as we had indicated earlier, the district-based surveillance response has provided some protection and relief thus spared for the province in the second wave. Intersectoral collaboration was also found to be pivotal for effective and efficient response for outbreak of this magnitude. And effective disaster management plan and team serves as blueprint in the adequate response, and surveillance, as the MEC has indicated, remains our cornerstone for effective response to cap the spread of an outbreak. So the preparations of the resurgence of the third wave has to commence with immediate effect, in particular with the focusing on the following. The district less affected in the second wave, admission capacity, especially ICU in public facilities. We need to strengthen containment and institutionalization of the response. And of course, we need to lastly incorporate other healthcare services in the resurgence plan. So that plan, Chairperson and honorable members, is well underway in terms of how we're going to deal with the aftermath. We have instructed the district health services that they need to come and present, a catch-up plan that they need to implement just to deal with this aftermath. So, Chairperson, if you allow, I will go straight into the next presentation, which is the vaccine rollout, and perhaps immediately thereafter we can then field questions and answer session.
Please do. But I noticed that your vaccine rollout presentation is just too long. We have read it. Try and go through it without going through details on each and every slide.
We'll do that, Chairperson. I'm just going to... I'm just going to open that, Chairperson.
Honorable members, you can start sending to me your request to engage with the presentation. I've started receiving some, continue doing that.
I'm just trying to end the show, Chairperson, and start with the new presentation, which I will do in a second. Are you able to see my slides, Chairperson?
Yes, sir.
Thank you very much. I'm just trying to check quickly. I will immediately start. Thank you very much once again for the opportunity. We are going to start right on top or at the top with the presentation where we are, of course, this presentation is the presentation to the Portfolio Committee on Health in as far as the Free State COVID vaccine rollout plan. The presentation has the table of contents, which I'm not going to spend much time on, as Chairperson has indicated that the presentation is a bit too long, but we'll try and really run through the presentation. So I'm not going to go into the table of contents. Suffice to say that Free State, in terms of the geographical location, is indicated there. We have a population of about 2.9 million people. The density is about 201 square kilometer, and we have 5 districts, as I've indicated. The next slide is just to show you, in terms of the goal of this vaccination rollout, that we need to vaccinate at least 67% of our population. Now, this is for us to be able to reach what we call herd immunity or population immunity. Now, the indication is that given the fact that we have 2.9 million people, we need to vaccinate about 1.9 million people. And now this is an indication of the population per district as per the source that we have is our Stats South Africa. So this is the mid 2020 stats that we received. So in as far as first data is concerned, we need to vaccinate about 341,000, literally puts 437,000. Mangaung, 583,000, Tabumputsanyani, 512,000, and Harib, because Harib is really the smallest district in our province, we only need to vaccinate about 86,000, as it were. Now, the next slide is just an indication of the demographics in the Free State. It goes to the level of detail in terms of the household size, the number of people above the ages of 65, as well as the people that do not have, your flushed toilets connected to the sewer, but also the people that do not have water inside their dwelling. And then, of course, the number of people that depends on social grants for survival. Now, this, Chairperson, is an indication that because of its rurality, the Free State province would ordinarily have, in terms of the social determinants of health, would ordinarily be at risk in that regard. Now, we are saying that approximately 300,000 people in the Free State are above the ages of 60, and 30 to 40% of the Free State are rural and lack of appropriate access to routine healthcare. The goals that we developed in as far as the vaccine rollout is concerned, or the plan, as it were, we need to ensure that there is safe, effective, and efficient, as well as agile provincial COVID-19 vaccination program. And we also needed to make sure that we build a public health response to COVID through the efficient provision of safe and effective vaccines to the population of the Free State, thus reducing serious illnesses and death as a consequence of COVID-19. The objectives, Chairperson, I will just quickly run through them as well, in that we needed to develop and implement a provincial plan that is based on the national implementation plan. And of course, we need to identify target population, service points, availability of vaccinators, and transport and supplies. But we also need to ensure that healthcare workers registers on the system and all of them gets vaccinated. And the department should also make sure that we avail resources to be able to procure needles, syringes, waste, and of course the waste disposal shouldn't be an issue. And we needed to make sure that on a constant basis, we liaise with the National Department of Health regarding distribution of vaccines, which I think is an emerging challenge now, according to the report that I got yesterday from my colleagues, in that vaccines are not coming timelessly. Monitoring of coverage and stakeholder liaison, including liaison with the private sector. Now, we then needed to, as we agreed on a plan, we needed to establish a structure which we call a vaccine committee structure, and that is as depicted there. But in the main, what I wanted to demonstrate here is that it has different streams that are responsible for each area of what it's supposed to do. We have the governance and stakeholder, vaccine cold chain and logistics, service delivery platform, HR and training, information and M&E, and safety, as well as safety surveillance, as well as communication and demand creation. Now, Chairperson, we then went on and said we needed to develop roles and responsibilities for all these people. So we needed to then make sure that there's a task team that is mimicking the team at the National Department of Health. And that task team would ordinarily or in the main be responsible for the following areas that I've talked to, which is the development and implementation of provincial-based plan, identifying the target population, which is more or less similar with what I've already touched on. So I will skip for that reason, Chairperson. Now, at the provincial level, we have a governance and coordination structure, which is led by me. It meets on a weekly basis. Where necessary, we will then meet, even twice a week to make sure that things are happening. In that, we get people to report on the progress, on the responsibilities that we're supposed to be taken care of, and we hold people accountable in terms of, because we take COVID-19 and vaccination thereof as a serious imperative for this Department of Health. Now, the vaccine structure, we, as I indicated earlier on, we decided to decentralize this structure in terms of the district-based approach with district directors, and that's the reason why I also invited them as project leads supported by primary healthcare managers of each district and filtering down to local areas, as it were. The governance and coordination structures must be aligned to that of the province, as we are aligning to the National Department of Health, but also the district epidemiology EPI coordinators should form part of crucial, which is crucial for the district. My apologies, Chairperson. I just got disturbed by somebody who wanted to come in. I've been given a task of co-managing this platform, so it really is disturbing me. So I was then saying lastly that the district facility pharmacists will be responsible for the cold chain. So you can see that already in terms of our planning, there was a deliberate attempt to make sure that we become seamless in dealing with this vaccination. Now, the next slide is the slide that I know that all the members would have seen from various other provinces. This is a slide that talks to the faces, and I'm not going to go into that. Suffice to say that under phase one, where we are at now, we are in a process of making sure that we vaccinate all our healthcare workers, because our understanding is that these are the first line. This is the first line of defense that we need to strengthen and protect. Now, in terms of the province, Chairperson, if you look on the right, we are just presenting to you and members the total number of healthcare workers that we need to vaccinate in the province, which is sitting at 36,993. Now, we've then categorized them on the right in terms of those conducting certain procedures, Category 2, those in direct contact with known or suspected COVID in that order. So that will help us to actually be structured in terms of the approach of the vaccination of these healthcare workers. But we are experiencing already some challenges, which we are already, we have begun to, come up with a mitigating strategy as to how we're going to deal with that. If you look at this slide, the question here is that how will the healthcare workers access the vaccines? And we are indicating in terms of place of work, category, and where they're going to be vaccinated, as well as their responsibility thereof. I'm not going to go deeper into that. But in terms of the next slide is where we are trying to depict, or rather demonstrate, the sequencing and prioritization that we're going to embark on. And we have indicated that in terms of sequencing, we have sequences of 1, A, B, C, and D. And we then indicate as to how that is going to be done. In terms of prioritization, we have indicated earlier in terms of the patients that are, the patient-facing healthcare workers, and that is going to be followed in that manner. This has been discussed with all the role players, and there's an agreement as to how this is going to unfold. Now, once we are done with the phase 1, we will have to go deeply into our phase 2, which is going to be a mammoth task, but we are already preparing, Chairperson, in terms of strategies as to how we're going to deal with that. You would remember that phase 2 is mainly going to be your essential workers, persons in congregate settings, persons 60 years and older, persons older than 18 years with comorbidities. But also phase 3 is going to be persons older than 18 years. So it's going to be literally everybody remaining in the 1.9 million population that we have. So then on the right-hand side is just a definition in terms of who these people are, and I'm not going to go into that. I'm just going to run quickly through the work streams that I've indicated to earlier, that in terms of service delivery, we need to firstly identify the target population and identify COVID vaccine delivery strategies and outreach strategies, and identify vaccination sites to ensure that sites register on the online portal. And we need to also make sure that there are no gaps in terms of delivery through private facilities. As you would know that as the custodian of health, we are supposed to be delivering the service to the private sector as well. And we need to, from time to time, update protocols of infection prevention and control measures, and develop and review vaccination site accreditation and readiness assessment across all levels in the public and private sector. And we need to ensure that we have ultimately sufficient vaccinators. Now, this is just an indication of the tool that we're using in terms of the facility readiness checklist. Now, no facility chairperson and members is going to be allowed to participate in this vaccination rollout unless they tick all the boxes in as far as this tool is concerned. And where there are those that do not tick all the boxes, we have put measures in place in making sure that we support them to be able to tick all the boxes. The vaccination team structure is going to consist of the list that I've indicated there, which is amongst others, Q marshals, COVID screening team, vaccinators, data capturers, observers, observers of vaccinated individuals. As you would know that we are also anticipating adverse events. So we need to make sure that we have that. And then of course, monitors and supervisors. The human resource and training here is just an indication that we need to make sure that all that HR make sure that they verify the details contained in the database of all healthcare workers in the province, and help us to categorize these healthcare workers in terms of the phase as indicated, but also in terms of the prioritization. And then they need to make sure that they develop a provincial training plan across all participating facilities, because we need to have enough vaccinators, so those must be trained. and then contact visual and or persons trainings, which they've already started doing, and they are doing that with the Knowledge Hub of the National Department of Health. We also have what we call an ICAM studio that we are using to reach out to. I think we can connect to more than 30 sites in the province, so we are able to do that, as an innovation. Now, in terms of the support from the National Department of Health, this is what I've indicated: the Knowledge Hub, and training has already started from the 15th. Which ended on the 27th, and all our healthcare workers who were eligible for this training have been trained. Now, the other important thing is that this training also is CPD accredited. So for those healthcare practitioners that needs to update their CPD points on a constant basis with the Health Professionals Council, they will then be able to do so. This slide, Chairperson, is just an indication which tells us, or at least gives us an idea as to when we get the vaccines from the supplier, how is the process flow going to unfold. The medical depot is going to be the main recipient from the supplier, and from there, the medical depot will then register and make sure that every detail that needs to be registered or recorded is recorded for purposes of audit, but also in making sure that we don't lose these vaccines. This is just the collection sites that we've come up with in the province. We deliberately looked at this, Chairperson, and we firstly decided that we needed to make sure that the vaccination sites or the collection sites would in the main be hospitals for various other reasons, which I'll talk to at a later stage. But in the main, it's going to be from the medical depot, as it will be coming from the National Department of Health as a donation. And I'll also indicate as to how the Johnson & Johnson is treated, because it's slightly different from the strategy that we have. Now, you would know that after the AstraZeneca chairperson fell off the table, we then started the implementation of the Johnson & Johnson, which is for the phase 1, which is the vaccination of all our healthcare workers. Now, this Johnson & Johnson, you would know that it's the advantages thereof is that it's a single dose, but in terms of handling, it's also much friendlier as opposed to other vaccines, in that the storage is only between 2 and 8 degrees, which is also quite helpful in that you can still store this in your normal refrigerator, and the plan, as I indicated, was that the medical depot will then distribute this, but we know now that because there were some conditions attached to this J&J, we are getting these vaccines from the people that are conducting the research. In our case, in the Free State, it's the Rocha institution that is conducting that. The province has currently 31 collection sites, as I've indicated, and with WHO pre-qualified refrigerators or walk-in fridges. And we made it a point that we avail resources for us to be able to procure these refrigerators. But as to how we're going to monitor this, the temperature in these refrigerators, we also made it a point that we cover that by making sure that we'll monitor with the fridge techs as a monitoring sort of tool to determine as to whether the temperature is adequate or not. Each collection site or vaccination collection site, I beg your pardon, has their own conditions plans in the case of cold chain failure. By that, I mean, there was a question that sought to understand as to what is going to happen should there be load shedding in some of the facilities. So they've developed plans in terms of generators, in terms of where do we move this to in the event that something like this happens. So that plan has already been taken care of. We are going to be using our RX solution, which is the system that we have for stock management from the depot. The next slide is just in terms of the data management and information system for monitoring and evaluation. It's just the journey of the patient as they come in and up until such time that they are vaccinated and they go back home after having been monitored. and having satisfied ourselves that there is no adverse event that we need to take care of, Chairperson. The next slide, just quickly, is the EVDS that has been much talked about. This we have been able to implement in the province. In fact, we are among the first that successfully implemented this with the support of our IT department. And so far, we are not experiencing any challenges except your normal challenges of the downtime and all that, which the national department is dealing with. The next slide is in terms of the stakeholder management, just to indicate that we've identified a target group that we need to concentrate on, which is your independent practitioners, amongst others, the private nurses, traditional healers, Department of Education, Department of Social Development, private pharmacists, private hospitals, religious groups, traditional healers, Department of Correctional Services, mining houses, large factories, tertiary institutions, and organized labor. I deliberately went through this list, Chairperson, so that it is well understood that we tried to cast our net far and wide in making sure that we communicate with everybody. The next slide is in terms of how we envisage to do patient safety surveillance with the National Department of Health as well as Sisonke. I must indicate that this is the slide from the National Department of Health. But what is important is that what you then do in the event that there is an adverse event. Once you've identified that adverse event, you need to complete a form, and we have a process of reporting that to Sisonke, but also to the National Department of Health, but also to keep that record as for the purpose of other, things that may come up later after we had finished with the process of vaccination. The next slide is the most important one in terms of communication. We've always said, Chairperson, we can do everything and anything, but for as long as the people that are involved, the communities and our staff as well, communication is not to the extent that it satisfies all their questions, we will not be able to get this right. So our approach is in terms of advocacy, capacity building and strengthening of the existing synergies, media engagement, then social media, social mobilization and community engagement, but also in terms of adverse events and crisis communication, so that we don't get mixed messages or misinformation in as far as this process is concerned. And we've also made it a point that when the J&J was rolled out in the province, the MEC was the first person to be, as a political head, to be vaccinated. And we made it a point that we share that far and wide with the community for them to see that there is nothing untoward in as far as vaccination is concerned. To quote the MEC in that, she indicated that she received her vaccine, she's feeling well, and she was asked the most pertinent question of where you are, when are you going to get your vaccine? So from that, Chairperson, I think the communities were able to be happy and satisfied that indeed there are no problems, even our healthcare workers, because there's a lot of vaccine hesitancy that we need to deal with. I'm not going to go into this, except to say that we also, with the University of the Free State, conducted a study just to try and deal with the vaccine hesitancy that I talked to earlier. And this is what we found, that actually we wanted to assess if there was vaccine hesitancy, what are the barriers and reasons. And from there, we developed communication strategies according to the findings that we got. And of course, that is going on very well, Chairperson, and we are happy that we are beginning to turn the corner in as far as that is concerned. Here is just to indicate, Chairperson, in terms of the J&J Sisonke project that is currently underway, that as the Free State province, there were only 2 sites that were chosen. Now, the conditions of the protocol, in as far as the study is concerned, was such that we need to identify 2 facilities that would be, in terms of proximity, not more than 5 kilometers from the research site, so that it can be easy for the research site people to take the vaccine to those vaccination sites, which in our case was Pilonomi and Universitas Academic Hospital. So this slide is just indicating that we were allocated 3,800 doses at Universitas Academic Hospital. At Pilonomi, we were allocated 3,080 doses. And the ratio in terms of allocation was that it was going to be a 2:1, meaning public, for every 2 that you would have vaccinated in public, you would vaccinate 1 from the private. And I must indicate that as at the 2nd of March, we had vaccinated about 5,780 against the target of 6,880. Now that shows that we really have worked hard, and we have encouraged the colleagues to keep up the good work. But just to quickly indicate that we've enlisted additional facilities, because our understanding is that if we are to finish all healthcare workers by April, which is the 36,000 number that I spoke to, we need to enroll more facilities. And we have enrolled thus far 1 private facility and 2 public facilities. One is in Fezletabi, which is Fezing Gubentombi. The other one is Bongani Regional Hospital in Lejwe-Liputso, and the next one is Live Rose Park in Mangaung. So this is just in terms of the batches and that information, as I indicated. Now, if you look at the next slide, we then looked at the vaccine allocation and catchment sites. And I've indicated the public facilities that we've enrolled, which is Bongani. And Bongani will then be looking at this catchment sites, and Fezing Gubentombi will then be looking at those. In terms of numbers, these are the numbers of healthcare workers that we are anticipating that we should be able to vaccinate. The next slide, Chairperson, is in terms of the tool that I spoke to earlier on, that this work was indeed done because we don't want to leave anything to chance. So a team did go out and make sure that they do this work. And the site preparedness readiness plans were presented to us on the 25th of February, and we were happy. And on the 26th, it was a meeting with Bongani Regional Hospital and Joshua Research Team. And on the 28th of February, it was the same meeting, but in this case with Chrismo Research Team, which is out in Kliptown. The reason for that was that we agitated that we do have now
don't change where you were.
Support from Chrismo.
Dr. Mtao, I don't know whether it's only me who's getting you to, we are breaking now. Dr. Tembegwa, are you getting the same problem?
Yes, I'm getting the same problem. We can't hear him.
For the past 2 minutes, Dr. Mutau, we lost you there. You just breaking. Did you move around?
No, Chairperson, I did not move around. As I indicated,
you are
before,
okay. You are better now.
Challenges.
You are better now. Continue there. Don't move. Don't move now.
Thank you very much. I'll try and run it. I'm just going to go back 1 slide back. It was just to report in terms of site readiness, which I'm sure the members have had. The next one was in terms of phase 2. I'm not going to spend much time on this because of the challenges of the network. And then the next slide, which I think is very important, as we plan for this phase 2 and 3, we needed to firstly, get a feel in terms of the distances between our facilities. So we we did this work with the University of the Free State, where we would take a Google map, but do an overlay in terms of the hospitals. And I'm not going to spend time, but you can appreciate that we have regional district hospitals, regional hospitals, national central hospital, as well as the provincial tertiary hospital, and lastly, the specialized psychiatric hospital. The next overlay that we needed to do and understand in terms of distances was the private facilities that we have in the province. So we have currently 27 sites that are depicted on that map. The next one, which is going to come in handy, especially when we go to phase 2 and 3, we needed to also look at the resources that we have because we are alive to the fact that our facilities alone will not be able to take us through phase 2 and 3. So we looked at the schools that we can use. So this slide is also trying to show us in terms of the schools, but also categorized in terms of the quintiles, the different quintiles. And there's an agreement that only quintile 3 and above can be considered. And this is a subject for discussion at some point because of the challenges here and there in terms of quintile 1 and 2. The next slide, Chairperson, is in terms of the stakeholder engagement that I've already talked to earlier on, so I'm not going to go in there. The capacity building has been done, as the MEC has said, with our partners, but also with GEMS in terms of HR, logistics and equipment, the University of the Free State, the military as well. In terms of what we've said earlier on, we're going to look at the phase 2 and 3 in terms of high-risk priority groups and general public service delivery platforms. And we've come up with the 4 areas that we need to look at, which is work-based vaccination, facility-based vaccination sites, mobile outreach-based centers, which we have to consider, especially going into the outer phase of vaccination, but also the issue of private vaccinators is also a consideration. And on the right, it's really just to deal with the phase 2B, which is persons in congregate settings. Lastly, Chairperson, I just want to take 2 minutes of your time to say, in conclusion, the department has put systems in place to roll out the vaccine program as planned. The successful implementation of this plan will depend on a number of factors, which includes but not limited to availability of adequate vaccines to cover the population of the Free State, aggressive demand creation efforts to counter vaccine hesitancy, amongst others, robust risk communication and community engagement programs, which I've indicated we are dealing with, stakeholder engagement and collaboration, which is very key. The plan will be reviewed constantly to check if we are still on track, especially when dealing with phase 2 and 3 respectively. Now, lessons learned from the phase 1 rollout will assist in enrolling more facilities across the province and also implementing phase 2 and 3. But it is also important to underscore the fact that this plan will not be realized unless we have enough budget or adequate budget to deal with this. Chairperson, I'd like to take this opportunity to thank you and the members for giving us an opportunity to present to you. Thank you.
Okay. Dr. Mutau, I hope your next job is not going to be a pastor or a preacher. But thanks for the presentation. The honorable members have indicated their desire to engage with the presentation. Honorable members will do the same as we would do, whether I come once and read your number and your name, then you just follow one after the other. Thanks, MEC, thanks for the presentation, and thanks for the HOD. Our members who would like to engage with the presentation are in the following order. The first one is going to be Honorable Gela. Number 2, Honorable Sokacha. Number 3, Honorable Ismail. Number 4, Honorable Chirwa. Number 5, Honorable Tseke. Number 6, Honorable Hlengwa. Number 7, Honorable Dr. Tembegwayo. Number 8, Honorable Wilson. And so far in the list, the last one, number 9, is Honorable Dr. Jacobs. In that order, honorable members, can then we start with Honorable Kela?
Thank you very much, Chairperson. Let me welcome the presentation from Free State Province. We really appreciate the good work that we are doing as a province. And I'm happy, comrade, about your vaccine rollout plan as a province, but to also to applaud the MEC for the good work and also for leading by example, for being the first among the people who were vaccinated in your province. That shows a leadership, and we are happy that we had that. So far, there are no side effects in terms of the vaccine. We are saying keep it up with the good work. I know we still have a challenge, but also will overcome this pandemic. Chairperson, also to thank the HOD for the presentation of Free State. But my question, Chair, is follow. The first one question is about the brigades that are deployed throughout the country, the Cuban brigades that are being deployed to the whole country. I just want to check with the province how many that were allocated in the province of Free State, and also their contribution, whether they are adding any value in the province. The second one, Chair, it's the issue of our healthcare workers. They were so exhausted, the fatigue that was reported even in other provinces. I just want to check the support that they give our healthcare workers in the province. Then the other one, Chairperson, is the issue of the demand for the beds in the province for both private and also public hospital. But also if they can share with us the relationship between the private and also the public hospital, if there's that relationship. Free State, it's mining province. Would like also to hear the relationship and also the assistance from the mine. If there were any donation that they've received as a province, if they can also share with us that, a Chairperson. But also the other question, Chairperson, that I want to ask, it's about the disposal plan for medical waste. As we know that we have started the out of vaccinating people in the whole country. If they can also tell us more, and the issue of EMS, because the province is vast, we know if they have also challenges, but also in their challenges, Chair, they've also highlighted the issue of human resource. If they can also just share with us, Chairperson, whether they have also requested additional budget from the Treasury to recruit more healthcare workers, and also to procure additional equipment such as EMS vehicles to cover the province. The other one, Chairperson, it's the issue of mortuaries in the province.
As you know that we have lost many people due to COVID-19, the relationship also, what they've experienced in terms of the mortuaries, if they also cover that. My other question, Chair, it's a concern that was raised throughout other provinces, as you are the last province that we are meeting today. It's an issue of high demand for oxygen. We heard there were some challenges in terms of AFROX, but also we want to check whether you did have also experienced the same problem of oxygen, whether to have any plan in place or procuring locally when you experience a challenge with the oxygen from AFROX. So, Chairperson, the other issue, my last issue, Chair, the last issue, actually, I'm happy, Chairperson, about the facility readiness checklist that we have developed as a province to also check and also whether you are also fast-tracking and implementing accordingly to your checklist. But in terms of your challenges that you have highlighted, I believe that you are going to address as a province, because you do have a capacity to make sure that at least you address all those challenges. But my last Chairperson concerned under your challenges, it's a poor performance on key strategic program. For example, the issue of HIV, AIDS, and TB. I just want to check whether have you already improved that poor performance or what is happening, because in that case, we may find that there are people will be defaulting because of the poor performance, who are not coming forward so to come and collect. And also the issue of budget cuts that was done in the province, whether have you resolved that and go back to the treasury, because I believe that you have also highlighted there were some delays also in the infrastructure. So in that, Chair, those are my questions, but also appreciate the good work that the Free State is doing as a province under the leadership of our MEC. And we are saying, Mbokodo, continue with the good work that you are doing as a province. Thank you very much. Malibongwe.
Thank you very much, Chairperson. Is it me?
It should not be such a big pause, honorable members. I've read your names. When the other
Thank you very
members
much, Chair.
done, you come in.
Thank you very much, Chair. Chairperson, let me take this opportunity and congratulate the MEC and the HOD from the Free State Province. I must say, Chair, it's one of the best presentations that I've listened to from provinces. And I want to really say to the MEC and the HOD, keep on the good work that you are doing in the Free State. Chair, some of my questions have been asked by Comrade Keller, the issue of ambulances, and also the issue of the oxygen. I want to say I really thank the HOD when he outlined the communication strategy that the Free State is following, which is to me key. He was correct to say it's one of our key, campaigns to make sure that our people understand the issue of vaccination. I really want to say thank you very much for that key area, because I wanted to ask a question about it, but you have clearly outlined it. My first question, Chair, is around the training of healthcare workers in terms of those that are going to vaccinate our people? How many have the Free State managed to train? And secondly, Honorable Chairperson, on the lessons learned by the Free State during this process of COVID-19, I just want to check, what have they learned vis-a-vis the implementation of the National Health Insurance? We're about to implement the National Health Insurance. What have they learned, the issue of the COVID-19 vis-a-vis the implementation of the National Health Insurance? Those are the few issues that I wanted to check, Chair. Thank you very much.
Thank you.
Good morning. I'm Hasina Ismail. Thank you for the presentation. Firstly, I've received many calls and complaints regarding the shortage of medication at some of the clinics. Please, could the department provide a full report on the availability of medicines at clinics?
Can you improve your communication gadget? We can barely hear you.
I shall certainly try. Chair, is this better? I'll just start once again. Good morning and thank you for the presentation. As I've stated, I've been receiving many reports from residents stating the shortage of medicines at some of the clinics in the Free State. Please, can the department provide a full report on the availability of medicines at the clinics? I'm talking about diabetes, hypertension, etc. Secondly, I've also received many reports of non-maintenance of clinics. I'm talking about clinic buildings, and in some cases, there have been reports of no water and no electricity. Please, can you provide a report on this issue, what was being done or what is being done to address these? Thirdly, lack of security at all health institutions is also a major issue, as it's putting lives of staff and patients at risk. Please, can the department provide a report on how the security issues are being addressed presently and what issues were faced in the past if they are not present right now? Also, can the department provide a full report on vacant posts, both senior and normal posts, please? Please provide a full report on the air ambulance contract tenders. Who has allocated the tender and how much was the tender for? Because I believe there's lots of, controversy on that matter. The issue of mortuaries was already asked by my colleague. I note in the presentation that the presenter stated that some healthcare workers are hesitant. Wouldn't you say this is because it's a trial and not an actual vaccine? Which actually goes to my next question. Since the Johnson & Johnson is a trial, if there are any adverse reactions to a trial vaccine, who will be liable for such? Is it going to be the National Department of Health, or is it going to be Johnson & Johnson? Is it going to be SAPRA? Is it going to be the Medical Research Council? Please advise. Also, please explain the non-interruption of medical care for healthcare users with chronic conditions. We would like a report on that one. EMS, although it's been touched by my colleague, my question is slightly different. We all know that EMS services has been highlighted as extremely strained and worsened by the non-satisfactory long-standing with the lazy EMS contract. Please explain in detail how the department has improved services in the context of COVID-19 and normal services. Also advise if the department is still using lazy EMS or another service provider as well. What is the status quo of intern doctors in the province? Please, can you provide a breakdown of all community service doctors per category per hospital and how many have been incorporated in the system thus far, considering that we have a shortage of healthcare workers? Explain the extent of the impact of the Johnson & Johnson vaccination trial has had on delivering services, as most of the healthcare workers are transported from far areas to the few trial sites. So has this not impacted service delivery while our healthcare workers are, on this side to get their vaccinations or their trial vaccinations? Thus far, how much has the department incurred on the transportation of healthcare workers from places of work to vaccination trial sites? My last question, how is the data for the Johnson & Johnson trials compiled and submitted, and who is actually responsible for this data in the province? Thank you, Chair. I hope I was audible.
Thank you, Chairperson. Thank you to the province for their presentation. I have a few questions as well. Firstly, with the country having moved to the level 1 of the lockdown, I'm particularly interested in the measures that have been put in place for prevention purposes, especially because the third wave was already predicted and the fourth wave was already predicted as well. Can the province just extrapolate on government efforts in relation to response, particularly on mass communication campaigns, on vaccination, on the 3B trial of Johnson & Johnson, and other viable alternatives in terms of vaccination? What kind of the province for communication purposes and ensuring that communication reaches people, no matter how it is deemed as important or not, in the current progression of the issue of vaccination? Number two, I want to know what the view of the province is on the gate nation by national government, especially because as of late, far-right groups have communicated their discontent that the private sector and medical are inconvenienced by the gatekeeping. But there are obviously much more intricate reasons on why the nationalization of procurement can be problematic. Example, the choice of manufacturers like Johnson & Johnson and AstraZeneca, even though there were other viable alternatives that were immediately available for in the context of a provincial health government. There might be different reasons cited in this regard and how it affects the trickling down of mass vaccination. Please kindly just assert what the position of the province is, noting that you asserted that there is a good working relationship between the private sector. It's very concerning that you are also perpetuating the misinformation that's currently undergoing in South Africa. Phase one has not started. We are currently doing a 3B trial of Johnson and Johnson, and it is deeply concerning that provincial governments come in and note that phase one of the vaccination program has started in their provinces. SAPRA has not approved a phase one or a progression of a Johnson & Johnson vaccination program, except for research purposes. And in your presentation, obviously in the communication that you put out in your provinces, in your hospitals, this is not communicated.
Sorry, Chairperson, we are struggling to hear what the honorable member
They're
is
even missing a
saying.
portfolio committee of health. I mean, how of a vaccination program when we are all very knowledgeable, despite Department of Health and the Minister of Health and President Cyril Ramaphosa approved a Johnson & Johnson vaccination program. Sorry, am I audible? Am I audible now?
Okay, I really struggled to hear what you were saying.
Oh, okay. No, I'll repeat it again. I was noting my concern in relation to you guys citing that you are undergoing a phase one in the province of the vaccination program, because we know it is not the case. The country is undergoing phase 3B of the Johnson & Johnson trial, for which SAPRA has approved. SAPRA has not approved Johnson & Johnson for a vaccination program. They've only approved it for research purposes. And it's concerning that you're also complicit in the misinformation and misleading the country and the province and the healthcare workers on what exactly is happening. So I want to know, what processes are you following, especially in regards to facilitating the research of the vaccine trial, phase 3B, and why you are presenting to the portfolio committee as phase 1 of the vaccination program, when we are fully aware that phase 1, in actual fact, has not
Honorable Chirwa,
if we
Honorable Chirwa, your communication is really bad. Your line is not good at all today. Honorable Chirwa, your line is bad. Your line is very, very bad. Can we skip you and request you to write down your other questions? It's just not coming through at all. Honorable Tseke, please take over.
Thank you very much, Chair. I would not switch on my video because of the network that is unstable. Let me thank the Free State Province for its presentation, and also wants to appreciate and thank the department led by the MEC and the HOD Mutau for really flying the flag of this government very high in terms of saving the lives of our people in the province. And also our appreciation to the healthcare workers, Chair, who has been at the front line in making sure that we protect and save the lives of our people, Chair. I think this is the message that we have to convey, Chairperson, to the province. And Chair, my questions really, some members have covered them. And one other question that I want to ask, Chair, it's on the presentation generally does not cover the healthcare workers who have been exposed to this pandemic, how many have recovered in the death cases, Chair. Or I think I've missed the slide that talks to that. My other question, Chair, is on just to check if the province or the community health workers is still embarking on a door-to-door screening process, because that process will be able to assist us in terms of spreading the message of government of sanitizing, washing the hands, and social distancing, and avoiding attending all these activities where there's large crowds, and actually spreading the message on the hesitancy that our people are having in terms of taking the vaccine, Chair. So my question is whether we still have programs on screening, door-to-door screening, and testing. Chair, the presentation also does not identify the hotspot areas that we have in the province and the programs in addressing them, Chair. I think I'm interested also in the hotspots in the province. My other question, Chair, in some provinces there has been an incidence of inability of the private healthcare facilities not coping with the admission of patients, especially when the country was hit hard by the second wave. I just want to check if the province have experienced that challenge too, and how was it resolved, Chairperson? The MEC in her opening remarks did indicate that instead of opting for a field hospitals, they went to a model of upgrading and refurbishing their infrastructure, the existing infrastructure. I'm interested in knowing all those hospitals where there were upgrades, and how far are they in terms of the upgrades, Chairperson. On the other matter, Chair, how much of the PPE tender corruption, if there's any in the province, has been uncovered either by the SIU or the AG, in the province, if there have been any officials who have been charged or held accountable, Chairperson. And my last question, Chair, is on the generally throughout the country, there's been an outcry or a reluctance of the law enforcement agency in terms of implementing the protocols, Chair. So I'm trying to check what is the situation in the province. Do we have such cases, or do we, or the law enforcement agencies, are they part of our meetings, our district command council, our local command council, wherein they'll be able to report and in terms of their programs that they are doing in our country, in our communities, Chair? I think those are my few questions, but the rest has been asked by members of Parliament. Thanks very much.
Okay.
Thank you, Chair. Yes,
Mamushengwa, sorry, I will invite you just now. Let me read the questions for the members, the panel to take note of. Ms. Chirwa is not able to log in successfully. She has, however, forwarded me her questions. I scrolled here and saw that I do have a number of the HOD. I don't want to bother the MEC. I forwarded them to you, HOD, but let me read them for the members so that maybe we will not have to repeat what she has asked. One, it is concerning that you note a vaccine trial as phase 1 of the vaccination program. It has not started. It's still a research phase 3B for what is approved for. How many people are participating in the Johnson & Johnson vaccination trial? What procedure was followed as per the processes of SAPRA on trials? And are the healthcare workers fully aware that they are participating in a trial or not necessarily an official and approved vaccine program? How did you make them aware? The next one, during the parliamentary hearings in the Free State, it was brought to our attention that the Buthelezi EMS contract made the EMS services worse in the province. How was this issue resolved? And is Buthelezi still the service provider? If so, why has the province not increased government capacity in relation to EMS in the province? The next one, how many community healthcare workers were absorbed since last year, and when will they be made permanent in the province? How many contracts have been terminated, and what was the reason? The next one, do we have any damaged or spoiled dosages of the vaccines for the Johnson & Johnson trial in the province? Can we be furnished with the numbers to this effect? The next question, what is the relationship between the department and the basic education department in the province, noting that schools have opened? What role does the department then play in the prevention of the spread? Next one, quality information access on deaths, recording of COVID-19 related deaths, accuracy, and if there was ever a misreporting of deaths, and how that affects or affected communication strategy and data collection. The last one, how many vaccination sites, facilities currently tick off the boxes of the criteria presented, and how many don't? Numbers, please. What will be done to get them ready, and when, by which dates? These are the questions that you can then be noting. I'm forwarding them so long to you, Dr. Mutau, then you can start working on them too with the questions that are coming in. Sorry for that, Mam Shengwa. It's your opportunity now to ask questions. Thanks.
Thank you, Chairperson. My network is not stable. That's why I'm switch off my video camera. Let me first accept the presentation and thank the province forward the presentation and prepare this presentation and comprehensive presentation. Having said that, I have few questions. Number one, I'm very much concerned about the awareness. In terms of awareness, I never heard the presenter or the HOD talk about the awareness. When will the public be informed about vaccine and how many dosages will the province receive of this vaccine? Number two, what is the status of studies on the effectiveness of using vaccine in the province? Third, in terms of human resources, you speak of poor skills, poor performance on key strategies, etc. What plan would you put in place in order to put this thing in order or to stop this poor performance or poor skills? What is your plan put in place? Lastly, this is a concern. You speak about the rationalism. It's a concern. How do you deal with this issue? One would seek a clarity in terms of that. Thank you.
Thank you, Chairperson. I won't be able to use the video because of the problem of connection. But I just would like to say, because the district representatives are present here today, just to say, to mention only 2 cases that needs attention because there are problems in the clinics around the province. The first one is the situation at Alfred Lituli Clinic at Wesselbron, where there is a lack of PPEs, according to the information that I received from the public. They say there's lack of PPEs, and it has also affected the working condition of the staff members. And obviously, during the COVID-19 era, there are restricted regulations, and the same regulations that apply to everybody should also be observed within the health sectors. I just would like to know what is it that has been done to solve this problem, not only at this clinic, around clinics, all the clinics, preferably in the province. The second one is Mabana Clinic in Mangaung, where there is a report of infrastructure dilapidation, and mentioned that the ceilings are falling in the building. The basins for washing hands, I mean, we're talking about one of the strict rules of COVID-19 is washing of hands. So if basins for washing hands are broken, then how are they able to apply those strict regulations of so it obviously means that clinic is COVID-19 non-compliant. The other problem is that community health workers, it's reported that they are struggling to get their salaries in time. Yet the MEC mentioned that they are going to, or they are employing extra health workers on a contractual basis. And then you are employing people, you have existing health workers, but you have a problem of paying them in time. can you in actual fact advise us on this problem and how you are going to solve it? People do work for the whole month and expect to be paid, as you also as an MEC or all those entourage that is here today, they get their money at the right time. So what the other question that I would like to ask is that since that Johnson & Johnson is a trial, I just want to find out from you, have you already received some results from these trials, especially in connection with the recipients of the vaccine that experienced a negative reaction? And if ever there are, what is it that the system that is in place to help those that have already received this vaccine? And in another presentation, there was a report and numbers, large numbers given of the communities of people who do not have water and flushing toilet. And I think it doesn't end there. It's not only water and flushing toilet. I also think electricity will also be a problem. What is your intervention regarding the fact that the social development in your province, together with infrastructure department, to help you so that this high number of people who are lacking water, flushing toilet, and electricity can be accommodated, they can be helped, because you identified this problem. What are you doing in order to make sure that this problem is being solved? And the other question is, did you receive any donation from Gift of Givers specifically? If yes, can you brief us on what is it that they gave you? And if you received it, why didn't you acknowledge their gift? Very important. Is any of the entourage present here today from the province receiving any COVID-19 related tenders? Or is anyone related to the recipients of COVID-19 related tenders, including refrigeration, as it may be? And lastly, I just would like to know, how are you going to reach the rural areas in the province in order to supply the trials as it is termed now, and the storage facility, including transport to those rural areas? Thank you, Chairperson. Thank you.
Honorable Wilson, you'll be followed by Honorable Dr. Jacobs, the last one.
Thank you very much, Chair, and I hope that you can hear me. Thank you to the Free State for the presentation. It is appreciated. I think in principle, most of my questions have been covered by other members of the portfolio. I'll just raise my concerns. One is obviously the Johnson & Johnson and the statements that what we're actually doing now is running a trial. The Johnson & Johnson vaccines are still under trial. If that is the case, and it's quite concerning if it is, if that is the case, are people who are being vaccinated, in other words, are health workers who are currently being vaccinated, being advised that they actually form part of a trial? It's not compulsory to have the vaccine, so I think they're entitled to make that decision that do they want to be part of the trial and accept the vaccine now or not. I think that's important. My second major issue is the disposal, particularly health waste disposal. We have had serious reports about the disposal of health waste. And I'd just like to know, particularly as far as the vaccines are concerned, exactly what plans you've got in place for the disposal. In principle, the vials actually should be broken before being disposed of. because vaccines have been stolen in other areas around the world. People fill them with saline water and sell them off as a vaccine to people when in actual fact they're not being vaccinated at all, they're just getting saline water. One of the huge concerns, and we heard this a lot in our NHI hearings while we were in the Free State, is your EMS service. Your ambulances there have to cover one ambulance can cover anything up to 20,000 kilometers. That is totally unacceptable, and something really needs to be done in terms of your EMS, not just getting the ambulances, but appropriately qualified crews and appropriately equipped ambulances. This is a huge concern. We get a lot of complaints about this in the Free State. And I wonder, please, if you could bring me up to date on the situation with your mortuaries. It is an area where we receive a lot of complaints about the Free State, about delays in mortuaries, particularly as far as forensics are concerned as well. And I know the forensic laboratories are very often separate, but they are now going to become part of the national health system. So if you could please update me on the state of the mortuaries in the Free State. And I think in principle, I'm covered by everybody else. I thank you, Chair.
Thank you, Chairperson. Thank you very much to the Free State Department of Health and the MEC for the presentation. We appreciate this presentation this morning. We also acknowledge your planning for the future events. I think that when one works with people, and especially within the health services, it is important that one is acutely aware of what is currently happening and what one needs to plan for going forward. We're also aware that you are probably preparing your APPs and your strategic plans, etc. So included in this, I see your preparing for the third wave, that you have a facilities readiness check. And I also noticed that you're looking at facilities in the more distant areas of your geographical space. And also that you're working actively at your vaccine rollout plan. Currently, I can see that you're maintaining the program of the health services. And if you're not, if you could maybe tell us where there are challenges and that you are busy with a vaccine rollout plan to the healthcare workers. I think just to make this clear, phase one means that the healthcare workers are first in line and you have a clear plan with regards to those who are patient-facing, those are not patient-facing, and you actually have 4 categories of those where your non-patient-facing are in category 4 and you've graded them like that. So when one speaks about the phase one rollout, the fact that you are rolling out vaccines is the phase one vaccine. And I just want to speak to a question that was raised earlier. Not that I am answering on your behalf, but it is a concern that it is not put correctly. And then in terms of the World Health Organization pre-qualified fridges, I was asking myself, what are these fridges? Are they being produced in South Africa? What is the process of acquiring these? If you can maybe allude to those. And then fourthly, to understand your need to have COVID services provided at designated facility. For example, your bigger hospitals, I could understand it's because you need to share staff, you need to share resources, but it does make me quite worried, us expecting a third wave, whether you'll be prepared at your rural areas to have patients not being sent to central hospitals or to regional hospitals. What are you looking at that, especially in terms of oxygen provision at some of the facilities within the rural areas? And then how would you be doing what would you be doing with the decommissioned field hospitals? Do you have any plans for them? And if you have any, please explain that to us. And then lastly, we also notice that you have made decisions that at your level 3 of your sequencing and prioritization plan, you have given quite a bit of leeway to the facilities to decide who the people are who will be vaccinated at those. If you can maybe answer a little bit on it. Thank you very much.
Honorable members, thank you for those questions. You could then check MEC and HOD that there are certain questions that rhyme through all the other members that they would like to really get issues on. This is the last one that Honorable Dr. Jacobs was touching on the Johnson & Johnson trial vaccine. The issues again on EMS, we need to actually get your response on that. From my side, I would want to know, one, do you find any value add by the program by getting the Cuban Brigade to support you in your province? And where are they distributed in the province? Are they mainly urban, rural, or they are not really in a specific area? If then you could then answer those questions, MEC, HOD, and your team will appreciate that. Thank you.
Thank you, Honorable Chair. Honorable Chair, I'm going to request the HOD to start answering some of the questions, and then I will then come in the questions that would be left that I'll deal with. HOD, you can continue.
Thank you very much, Honorable Chair, MEC, and let me also appreciate the questions that have been asked in the candid manner that they've unfolded. Chairperson, I'll quickly respond to those that I will be able to respond to, but there are questions that are specific to districts. So in particular, so I will then get the district manager there to respond to. Otherwise, in fact, let me put it this way, the chief director, Dr. London, is in the call, so she will be able to touch on that district, but she'll also touch on the issue of community healthcare workers, both in terms of numbers and why they have not, or why they are not paid timeously, but also on the absorption thereof. And then if there's any other thing which is of technical nature, I will also enlist the assistance of other members that are in the call. Just to start with your question, Chairperson, in terms of the Cuban brigades, we received about 17 Cuban doctors who came to assist, and we then met and agreed that they should allocate it in the following manner as we are trying to respond to the first wave at the time. The second wave. We allocated 3 to Universitas Hospital just to help us deal with the surge at the time. We also allocated 3 to Albert Mzula, which the purpose was the same. We also allocated to Manapo, which is more in the rural area, but also Albert Mzula is in the rural area. Bongani as well, we allocated 2, so 2 was for Manapo, 2 was for Bongani. And then we then allocated the other 3 to assist in as far as Pilonomi, as well as trying to assist. And then we then had in the team, we had 2 epidemiologists which we allocated to Albert Nzula and Manapo, and then 1 was allocated to Botshabelo in that order. So Chairperson, we were able to derive value out of their assistance, and I think they have been able to do what they do best, which is assisting not only the province but the country as they would assist all other countries in the world. So I'm going to then shoot straight to the first honorable members' questions, which was Honorable Gela Anna, and I've touched on your first question. And the second question was, in terms of healthcare workers, there's been some fatigue creeping or reported, as it were. Yes, it's true, Honorable Gela, there has been some fatigue, which we have noticed, but not only that, there was also a question of fear and uncertainties as they wake up in the morning and go to work, as to whether they'll be able to come back, still in the same state that they would have been. And to that extent, we looked at various measures, but in the main, the psychosocial support that we implemented through our psychiatric hospital, where we instructed our professors to look into that, and they started rolling that out by interacting with this healthcare workers. But the most important thing that would ordinarily assist, which sometimes we ignore, is the fact that if a child at home would have suffered something major in their lives, you need a mother to say to that child, "It will be fine, my child." So we enlisted the assistance of the MEC to also engage together with the Premier, to also engage with these healthcare workers, making them understand the role that they are playing and how important that is to actually save our lives as the community of the Free State. So that has happened in that manner, and I am sure there would have been those that would not have been happy in the manner that unfolded, but those are in principle some of the measures that we've implemented. But the most important one for me is that realization by our principals, and then the psychosocial one will come in. You've asked a question around the demand for the beds for both private and public. Yes, there was a huge demand for beds. In fact, this is one pandemic that has taught us that we would be better off running a healthcare system, not a healthcare system that is disaggregated in terms of private and public. And for that, I think we need the universal health coverage, which in our country we call the national health insurance, like yesterday. And we've had so many examples that we can share. Firstly, the private facilities would be so overwhelmed that they decanted their patients to our facilities, and we accepted those patients because we understand that we are the custodian of health in the province. So there was no issue in as far as that is concerned. But in terms of the demand, we prepared quite early. As I indicated when I started without the slides there, that we did take a resolution or a decision that we need to develop so many beds. So in other words, every facility in the province was instructed to give us so many beds. And this was not a blind instruction. It was an instruction after we had done a facility assessment across the province. We sent one of our specialists to go across the province, facility by facility, district by district, to go and see what the readiness would be in the event that the following day we are hit with with the resurgence. So that work was done, and that has actually assisted us a lot. But there was serious bottlenecks in the private. We did not have a situation where we were full to capacity in our facilities that we had extended to accommodate this COVID-19 patients, to the extent that at some point we felt we did not need the Bloomshaw field hospital, and that is why now we are in a process of decommissioning that facility. The mining sector, yes, in the main we have our mining towns, or rather our districts that have mines or mining towns, and I'll ask the district director to talk to that. Otherwise, if he's unable to deal with that, I will come back and deal with that. But suffice to say that there is a relationship between ourselves and the mining sector. In fact, they, as a process of stakeholder management, you would have seen that I did indicate that we do interact closely with the mining sector. At a time when the lockdown levels went down and there was a return of mine workers, we did have an engagement with them, But it did not stop there. It also served at our the command center in the province, chaired by the DG and myself. But it also went as far as the Premier's coordinating council for coronavirus, where a presentation was made, and we were satisfied ourselves that we will not have problems in that regard. But also at the district level, we made it a point that structures like your district jocks are sitting. We made it a point that there's a doctor that is assigned in dealing with these issues at the mining area. The disposal of medical waste, I must indicate that we do have a contract currently that is running, and we piggybacked on that contract. But the honorable member at some point asked the question as to what plans do we have in the event that we're going to have or go into phase 2 and phase 3. Of course, we will sit down with the whoever the contractor is or the supplier service provider is, and we will raise all those issues. So in terms of that, we have noted, we will be dealing with that. The EMS challenges and HR challenges, the question was, did you request help from Treasury? But let me indicate that as we've always ventilated these issues at every platform that we get, we've always indicated that in terms of coverage and then vis-a-vis the number of ambulances, we are running very short of ambulances, in that the population of Free State is about 2.9 million people. Now, in terms of the norms, we need to roster at least 1 ambulance per 10,000 population. Now, if you do the maths, we then are supposed to be rostering 290 ambulances, but we are currently rostering 149 ambulances. And I'll quickly give you figures in terms of the districts. In terms of Fezletabi, there's 24 ambulances that are catering for that district, and we have numbers per district, per town. In terms of Lijolipuzo, we have 28 ambulances that are catering for that district. We also have 25 ambulances for Mangaung, and we have Tabumfutsanyani having 37 ambulances, given the size of the district that side. And of course, Harib has got 13 ambulances, and all of them have got numbers that are allocated per town, together with the type of ambulance staff that we have in that regard. We've also allocated, out of the list that we have, 24 ambulances to respond to COVID-19. And even in that, actually 22, I beg your pardon, where 4 is in Fezletabi. Lijolipuzo has got 4, Mangaung has got 4, and Tabumfutsanyani has got 6, and Harib has got 4. So those are the number of ambulances that are catering for our patients that would be suffering from or diagnosed with COVID, that requires transportation to higher centers for further management. Yes, we have requested, we are busy with our budget now, Honorable Member Akela, and we have put a request in terms of all the pressures. As I speak to you now, there's an executive council sitting where the issue of budgets is going to be finalized. But we know that we will not get enough money to can run the healthcare services. And that's why we've always indicated that the healthcare demands are such that they are increasing by the day. But if you look at the resources are constant in that we are unable to meet some of these demands. But we are continuing to come up with innovations and do look at how we can share resources to make sure that we still provide the population of Free State with not only quality healthcare services, but accessible quality healthcare services. In terms of mortuaries, we do have private and public mortuaries. We do have mortuaries in our facilities. Yes, we do experience challenges here and there in terms of the waiting times, in terms of delay. But part of the problem is that this is a discipline that it is not anybody and everybody that would want to be part of. So you'd ordinarily struggle in terms of recruiting and retaining this the specialists who would help you in as far as doing the autopsies, but also around the issues of forensics is concerned. But we continue to try and recruit as far possible as we can. To give you an example, we've had to at some point, renew a contract of somebody who had, according to DPSA, gone beyond their retirement age, but because of the quality of work that he was doing, we continued to renew his contract until we felt that this is becoming irregular in as far as the Auditor General is concerned, and therefore we needed to do or come up with something. Now, in terms of the high demand for oxygen, I can indicate that currently we don't have a lot of problems in as far as that is concerned. We have some positives that we can share with this committee, that all regional hospitals have bulk tanks, and these are distributed throughout the province. And all bulk tanks are monitored on a 24-hour service through a telemetry system that is on site. And we have a system that would actually ensure that we transfer or the transfer to these regional hospitals are well organized to the district hospitals. And then we also have taken a decision when we developed or when we planned for COVID that all our hospitals that would be treating COVID-19 patients, especially in large settings, will have high flow oxygen machines, and we've distributed this widely through the province. That is why perhaps in most cases, if you look at the number of patients that have been able to come out of this COVID in the province, I think we have done well in that regard. We do have some challenges though, in that we have small hospitals that are really still using your oxygen cylinders. Now it becomes difficult because your high flow machine will consume quite a lot of oxygen, so that becomes a problem in that regard. But we are able to put systems in place in terms of whether to transfer these patients as they require this high flow oxygen. And I think the skill that we've actually managed to develop is for our doctors to be able to identify patients that would need to be referred to the higher level of care in as far as that is concerned. I think there was a question on the poor performance on key strategic programs. I will leave that to Dr. London, but suffice to say that we instructed the colleagues to come up with catch-up plans, which we will have to be implemented, and they will have to be monitored from the side of the clinical cluster in making sure that we catch up and we give services to our people. In as far as the patients that would not have their medication delivered on time, most of our patients, especially for your antiretrovirals and TB and other chronic patients, have been enrolled on a system called the CCMDD. So we planned ahead on time to make sure that there's adequate supply in that regard. So they were given enough supply to last them for quite a period in order for them not to default in as far as treatment is concerned. The budget cuts, I think I've touched on that. There has been some budget cuts. I indicated at some point that we lost about 950 million towards the end of last year, your calendar year. This was against the challenges that we have in as far as COVID is concerned. And we were given back, I think, just over 600 million, which was not enough given the fact that the budget that was taken from us was a budget that we had already planned for as to how we're going to appoint staff, as to how we're going to provide services. And I must indicate that the greatest amount of that budget actually came from the goods and services. So we then had to see how we reprioritize and deal with the challenges as they were coming. Now, Honorable Sokasha spoke to the issue of ambulances. I think I've touched on that. the tracing of healthcare workers, I will then let Dr. London, I hope she's noting this, that she responds to that. This one was quite interesting for me, and I thought I needed to take this as to what lessons have you learned. I've already alluded, what lessons have you learned in terms of the current system vis-a-vis the NHI? I've already alluded to the fact that we have seen that together with private, we can provide our people with quality, accessible healthcare, but the affordability will become an issue. And the NHI is saying everyone will have a, well, the Constitution is saying that everybody has a right to healthcare, as reproductive healthcare. Now, the NHI will then be saying everybody will receive quality healthcare at the point of care at no charge, regardless of their income. So all what this tells us is that, and this is how we responded to COVID, that everybody needed to get that quality healthcare and at no charge. And well, I'm not sure on the private side, I would assume that, of course, they did charge them, but you then have a lot of our people that their medical aids would then run dry even before the year would have ended. So that becomes a burden now in the household. So the only solution to deal with all these issues, including many others that I would not have mentioned, is that we need to implement this NHI. That is our view as the Department of Health in the Free State. Honorable Hasina asked quite a number of questions. We're going to respond to them. The availability of medicine, I must indicate that in the province, as per the reports that I've been getting, our medicine availability has been to the level that the facilities and the districts do have medication. So the districts would then be responsible for making sure that the clinics do have medication. And in particular, you asked about the chronic conditions like your diabetes and hypertension. Now, what we've noticed is that in most cases where a patient would cry foul that they did not get their medication, it would have been where there would have been an item that was out of stock, but there would have been a replacement or an alternative in that manner. But the problem then becomes when somebody who's giving that service is unable to explain to this patient that this is your diabetic medication. Last time we had given you metformin. This time around we are giving you Mengen or any other, and it's the same product. It will do the same thing. It's only that the names are different. So we will continue to investigate that. But we are not saying here that we do not have at one point or another the shortages of medication. Now, there would be shortages as a result of supplier not supplying to us because they would have run out of stock. Remember, these contracts are held at the National Department of Health level. Now, they have a prerogative of running the process, the supply chain processes, and appointing those companies, which we are not in control of. But we have raised that at the National Department of Health. Actually, those contracts are held at National Treasury. Now, we are in a process of making sure that we correct that, because it is not them that are faced with this patient. It is us that are faced with these patients, because we are at the cold phase of service delivery. The non-maintenance of clinics, yes, we have a backlog, honorable member, in terms of that, but I must indicate that we do have a plan which we can share with you at some point in terms of how we plan to roll out our infrastructure plans. The challenge here is that we are coming from a disadvantaged past where some of our clinics were very small, others were not maintained as they were supposed to have been maintained. Now, you then get policy imperatives like your ideal clinic, for instance, that talks about how the clinic should be, and in terms of size, but also in terms of staffing and many other things. Now, as you get to that point, it means you then have to repurpose these clinics to be, requisite to what is required. Now, as you do that, of course, you would need resources. And if you look at the amount of money we are getting as a province, we are getting just over 500 million to deal with the infrastructure across the province, whether it's new build clinics or hospitals that we're building, whether it's upgrading and repairs, whether it's maintenance and all that. That has to feed from that 500 or so plus million. And that becomes a challenge, so that we need to then prioritize. And the plan is talking to that prioritization in how we're going to deal with that. The issue around no water and many others, this is not necessarily a problem that is facing the health department. It's an interdepartmental or a collaboration between ourselves and many other our sister departments. And this, in our view, is how we need to approach these things. When a municipality plans in their IDPs and all that, they need to indicate as to how they're going to solve this problem of water, how they're going to solve this issue around ablutions, because this to us, it's a serious social determinants of health. And the pandemic has taught us that if you wash your hands for 20 seconds or so and wash them with soap, some people would tell you other figures, but wash them with soap, you then are able to be in a position not to get infected. And these are the problems that we're talking about on a constant basis. The lack of security, it is true that we have serious challenges with security. You would remember that we insourced security in the past, and this province was the only province, or the first at least, to insource security. And where we are unable to have security, especially in small clinics that would close at 4 o'clock, we then instructed district managers to, in their plans, make sure that they make provision for the installation of alarm systems that will be attached to the alarm response companies or even the police station. But you would know that as long as you don't guard your asset, nobody will do that job better than you. So we still would experience some challenges where all these people that I've mentioned would come after the fact. But we are working on that in making sure that we deal with that. The issue of vacant posts, the DDG will talk to that. I don't have that slide readily available with me. The tender on the ambulance, yes, we do have a tender on the helicopter, and I think this tender was also audited by the Auditor General, and there was nothing untoward that was found in terms of the processes that were followed. There's only one helicopter that is currently operating in the province. We will provide the name at some point. Now, the issue around hesitancy and the fact that it has been raised in here that this process is a trial. Yes, our healthcare workers are informed, and we have identified this as one of the risks, if not the biggest risk, that we need to mitigate for. But let me also indicate that the fact that it is a trial does not take away the fact that we are vaccinating healthcare professionals. I think the honorable member at the end did indicate to that. It does not take away the fact that in our plans, a long time ago, even before we knew about the J&J, we had declared that we will first vaccinate our healthcare professionals. Now, what you would need ordinarily in a vaccine, and I'm hopefully responding to Honorable Chiro as well, what you would need in a vaccine are two things. You would need to have safety. You would also need to have efficacy. And this Johnson & Johnson has proven across the world that it ticks those two boxes. And you would also know that as of yesterday, the Americans have placed an order of 20 million vials to vaccinate their people. And they would have covered about 15% of their population. Now, we are doing this because after this Johnson & Johnson was approved by your FDA and many other regulatory bodies, we then undertook this process for us to be able to register with our own regulatory authority, which is SAPRA. And at the point where we shall have completed this mini trial or study, if you like, we will then be able to have this vaccine registered. But I must also hasten to indicate that Johnson & Johnson is not going to be the only magic bullet. Although it has advantages in as far as it being a single dose, but also the requirements for cold chain. We are not going to be able to depend on one vaccine to vaccinate all our population. So at some point, you will see some other vaccines coming in, depending on how available they are. So that is the process that is going to happen. But this does not leave the fact that we shall have vaccinated all our healthcare professionals. And in that process, we shall have concluded the phase 1. So I just thought I needed to capture it that way for honorable members. The interruptions of healthcare services, yes, we've indicated in terms of how healthcare services have been interrupted, where the MEC has also indicated that at a time when we experienced the first wave, we had to regroup and rationalize resources to respond adequately to the. So some healthcare services were interrupted. I'm talking here about your clinics at not private healthcare. I mean primary healthcare facilities. I'm talking about clinics at higher centers that were also put on hold because of the fact that the lockdown level 5 was in place and we could not afford to have our patients moving around. So we did make provision for them to get their medication. The issues around operations that had to be stopped, and that's why I was indicating earlier on that we have now come up with a plan as to how we're going to deal with this. The issue around how have you improved EMS and as it relates to Buthelezi, let me indicate firstly that the contract of Buthelezi is no longer there. In fact, we are not contracted to any service provider on the road ambulances other than the one that I've referred to earlier on. We, with the challenges that we have, we've had to sit down and look at how we rationalize this. You remember that EMS services is one of the most important services or that would create or enable access to quality healthcare services. Now, if you don't have that, you are likely to have serious problems. We have problems now in terms of what we call the delay models that we've talked about at every platform that we found. Firstly, the delay in terms of, we call it the 3 delays model. Firstly, the delay in terms of the diagnosis of a patient, and that has impacted mainly in terms of our performance on maternal mortality as well as your neonatal mortality. The first delay would be a delay in terms of firstly being able to diagnose and timelessly asking for help. But the second one would be the transfer part, which the EMS takes a bigger role in that regard. But also the delay in terms of the acceptance of that patient. But these are things that we all know about, and we've put plans in place to deal with them. The issue of interns and ComServes, I think we don't have a problem there. We've been given a list by the National Department of Health. These are statutory appointments that we need to deal with. So we have been given that list. We are dealing with it. The last time I checked, we had appointed more than 200 both interns and ComServes. But I'm sure we can provide that report in that regard. The impact on delivery of services, do you bus people or not? Certainly not, honorable member. We do not bus people to these areas because firstly we have serious issues in terms of shortages of staff. So we cannot compromise on service delivery by busing these people. The issue of vaccine and vaccinating them will come at a later stage. They will all be vaccinated. As you have heard that we are now rolling it out to other facilities. So our hope is that at some point, all of them will be touched and they will have jabs on their arms and they will be part of the phase 1 that we shall have completed. how much have you spent? Obviously, we have not spent any money in that regard. The data collection, in as far as the study is concerned, I indicated that we have a research, the research side that has been certified and appointed by the National Department of Health together with the MRC, which is doing all the data collection. But we have also said in the department that we need to have data in as far as that is concerned. To the extent that they've given us access to all the data collection systems at the National Department of Health, we will then have data in that manner. I think I've touched on questions that were asked by Honorable Chiro. I just want to check in terms of which one in particular I did not respond to, and I will do so shortly. Right, there was a question. There was a question that relates to the community healthcare workers, which I indicated that Dr. London will deal with. There was also a question in terms of that it is concerning that we are misinforming our people. I think this is not necessarily true because all our healthcare workers have been informed. Perhaps yes, some would not have understood well in terms of who and what this means. But I must indicate that we've only vaccinated just around 5,700, and all those that we would have vaccinated have been taken through in terms of signing a consent. In fact, we have 2 consent forms that there's an online one that they sign when they register, but we also have made the point that we do have a paper-based consent form for our purposes. Now, in there, you are giving a vaccinee an opportunity to refuse should they not agree with you in terms of what this process is going to be all about. But I agree with you that communication is important and that we need to deal with it as such, so that if we don't do that, there'll always be problems. The issue around the EMS, I think I've covered that. How many community healthcare workers were absorbed since last year? Dr. London will deal with that. Do we have any damage spoiled? That information is with the JOSHA, but in my reports that I get on a daily basis, we do not have any spoiled so far. What is the relationship between the department and the basic education department in the province as we respond to COVID-19, especially around the issue of prevention of spread when schools are opening? I must indicate that our approach in the province is that of interdepartmental approach. Now, as health, we are part of a SHE department, which is your social sector departments or cluster departments, if you like, which I chair. Now, in that meeting, we always make sure that our agenda speaks to the current affairs in the province. So at this point, COVID was a current topic that we needed to deal with. We then made it a point that every department, but in particular, the Department of Education would develop a plan that will satisfy the Department of Health as to how they are planning to return their students to classes. And you would know that they have adopted a phased-in approach, which we've always had a presentation done, and we've always interrogated that in that manner. So that is why, if you look at the Free State, not only that we are number 1 in terms of the results, but the fact that the number of infections in our students has not been that alarming. It is the collaboration that we have with that department. We also have a platform in terms of the coronavirus council that is chaired by the DG, where these presentations are made, and that helps us to make sure that we don't leave anything to chance. The next question was the quality information access deaths, COVID-19 related deaths, accuracy, and if we are misreporting of stats, how that affects the affected community, communication strategy and data collection. I think here I will indicate that on a daily basis, our surveillance team will generate a report. Now that report will be fed by the work that would have been done at district level in terms of the accuracy of data. But we would know that at one point or another, there would be some discrepancies here and there, that the surveillance team is quick and capacitated to deal with all those issues. And I'm saying this, because even the district managers are here, they signed that report that will go to the provincial surveillance team that will then form part of a daily report that we get, which will tell us, amongst others, the number of cases that we have in the province, new cases, that is cumulatively, but also even the number of deaths, as well as per district as to how many, which province is, which district is leading, what are the hotspots, whether we are still in line with the National Department of Health's plan and strategy. So that does reach us, honorable member, in terms of that. And where quality is compromised, we are able to interrogate that and make sure that our quality is where we want it to be. We are currently having a minor challenge in terms of the recoveries. I think our reports will show that our recoveries are slightly lower than where they are supposed to be, but we have now implemented a strategy on how we're going to deal with that. Part of it was the loss to follow up that we've had. So we are dealing with that as it were. The last question from Honorable Chirwa was that how many vaccination sites, facilities currently tick the boxes. In as far as the ones that are already vaccinating, all those do tick the boxes. But what we do is we've identified all these other facilities in the province. I've made mention of about 31 sites. All those sites have been assessed by the team, and they've satisfied themselves with what is required, and they've presented that to me as the potential vaccination sites that we must use. Now, as we go into phase 2, and probably lower down on our phase 1, we will then do another round of all these facilities. So in other words, every facility that would be chosen today, they must have chosen that based on the assessment tool that we are using, and they must have satisfied themselves before they can present it to me. And in that way, we will then be able to deal with that facility. Honorable Tseke, the presentation not covering healthcare workers that have passed on. My apologies, Honorable. I will quickly just give you the figures right now. We've had in the province the cumulatively about 4,544 cases that have been affected or infected by COVID-19. And currently we have only 34 cases that are active. We've had quite a good recovery rate of 4,396. And the deceased, sadly, may their souls rest in peace, are 66 in total. Now, if we disaggregate that in terms of the districts, we see Mangaung sitting right on top at 1,716, followed by Thabo at 902. And the one next will be Lijwali Butswa at 859, followed by Fezle Dabi at 700, and Harib is the last at 287. My apologies for that, Honorable. I think that was just a critical information that we needed to share with the members here. The community healthcare workers, Dr. London will deal with that immediately after my presentation. Hotspot areas, of course, we do, as we do our surveillance, we do look at the hotspots. You'd remember that Mangaung at some point was the epicenter of this COVID-19, but then it then changed, as you would know, that our epi data will tell us as to what now is, which area now is the hotspot, and we move in there quite quickly. So Harip at some point was a burning fire that we got worried about because Harip is very small, and if that was to turn into an inferno, we're going to be in trouble. So we do manage by identifying the hotspots, and we provide strategies as to how we need to go in there together with the district managers and the districts at large. Inability of private coping, I think I did touch on that. Upgrades of hospitals. Yes, we had a list at the beginning, Honorable Zeke, in terms of which hospitals in particular, but we then, instructed that hospital X must give us so many beds, and hospital. So we then developed a program from infrastructure which was clustered accordingly, and we were deliberate in making sure that we shared the clusters across the districts, and we were able to achieve that. Some clusters were, I think it's the last cluster which was not fully completed, but we have made it a point that it gets completed. So we did upgrade our facilities in making sure that we respond to this. And this is one good thing that came out of this COVID experience, that we were able to bring our hospitals up to a point where they are not only responsive to COVID, but they are at a stage that is acceptable in terms of the requirements of a hospital. Corruption uncovered. We did not have anything in as far as corruption is concerned as the Free State Department of Health. Our reports that we submit to the Auditor General, you'd remember Auditor General then was instructed to audit this process of COVID-19 procurement. So our reports, the first one and the second one, I think they were all fine, even the third one. But there was a decision taken at the Executive Council level to centralize procurement of PPEs. And the Treasury would then procure on behalf of all departments, and we will give Treasury our needs. Now, Treasury will then subsequently deliver to you in terms of the needs that you would have submitted to them. So what then happened was that they delivered some gowns, isolation gowns that were supposed to be sterile, which when we unpacked the boxes, we realized that these gowns are not sterile. We then alerted Treasury to intervene with the supplier, and we had a meeting with them, and for some reason, SIU got hold of that information, and then they started an investigation into that, which we welcomed. And I think the matter at this point is going to the tribunal, where health is cited because health was supposed to be an end user. But in terms of us being directly involved in that regard, we are not involved in that regard. The implementation of regulations and law enforcement agents. Yes, we do work with the law enforcement agents. In fact, the provincial JOG that sits every Tuesday has the commissioner of the police in the province sitting in that, and the decisions that are taken there are decisions that we are implemented. If not, the law enforcers will then make sure that that is implemented. So in terms of that, I think we are covered. Of course, you would find citizens who would not adhere to these things. And it's a matter of whether you have a capacity to deal with all of them. If you have to arrest them, do you have the capacity to deal with all that? But health, on the other hand, had made it a point that we strengthen our communication in as far as your non-pharmaceutical measures are concerned. Honorable Fengwa, in terms of the concerns of awareness, yes, we do have processes that we follow in terms of making sure that awareness is done. We firstly do it at the primary level with your community healthcare workers that would also spread the message, but we also do it at the provincial level where we have, and I must say, even in the district, there are communicators that would make sure that messages of awareness are sent across. But we also have in the department a directorate that is dealing with communication. But also at the Office of the Premier, there's a centralized process of communication by the province to all its citizens. So that has been taken care of in that regard. But we also have the Premier from time to time going into the media talking about the COVID-19 and the impact thereof and how dangerous it is. The MEC is always on radio every time, even at 6:30 in the morning or 5:30 in some cases, where she talks about that. Recently, she was on TV talking about that. So that has been taken care of. I also, including the members of the surveillance team, we also participate in that process as it were. The status of the study with the effectiveness of the using. The study is conducted by the MRC, and I'm sure they will be best positioned to can actually respond to this, but we will have an interest in as far as that is concerned. We do, however, have information in terms of the previous study that was done, which was shared with the entire world, that the outcomes were actually good. Poor skills that we referred to, I think these are skills in terms of some of the actual specific things that we talk about. And you would remember that we are linking these poor skills with the training that we needed to do, especially in areas of vaccination, but also in terms of understanding what COVID really is. And this is something that we are dealing with. The Honorable Dr. Tembekwayo asked a few questions, and I'll quickly run through them without compromising quality. I think one of the issue was as it relates to Luthuli Clinic, the district manager or Dr. London will deal with this, but this is unacceptable. I'm hearing this report today in this meeting, but we will deal with that. Mabana Clinic as well. It's a clinic that is part of our plans that we will deal with, and I think I've ventilated adequately in terms of the challenges that we have. Chairperson, am I still audible?
And that we are actually becoming very detailed, and please round up and hand over to other members that would like to also answer your question.
Okay. Community healthcare workers that are struggling to get their salaries, in as far as I'm concerned, there are no issues with them. There was some delay at some point, but that was dealt with. J&J trials, have we received results? I think I've talked to that. What is your interaction with the demographics? I think I've also touched to this, that it's an interdepartmental, intersectoral approach that we are trying to how we're trying to deal with that. Of course, I also indicated that it is a challenge for us in terms of the social determinants of health. Donations from the gift of the givers, I am not aware of any. I'm saying this because donations do come through to me for acceptance. So I don't remember seeing any such. If indeed they have donated and I've missed that in this presentation, I would like to truly apologize, but we would know in terms of who donates and what is it that they have donated. Anybody receiving any tender or related to the person receiving tenders, I am not aware, Honorable Tembekwayo, in as far as this is concerned, but this is a process that, or an area that the Auditor General is interested in, and they will audit it all the time. So in as far as I know, there isn't anything that has been brought to my attention in this regard. But should it happen, we will definitely take disciplinary steps against this person. The plans to go to rural areas I've indicated in terms of our expansion plan. As to the facilities, we've tried to include all facilities across the province, and that will address the issues around the rural areas. Honorable Wilson, J&J vaccination trial, are people being that are vaccinated being explained to, and whether there are forms that are signed? Yes, I've alluded to the issue around the consent forms that are signed. And I think the disposal is what I touched on. I also touched on the EMS problem, the challenge that we have. Situation with mortuaries, I've also touched on that. Phase 2 and 3 as questions that were asked by Honorable Jacobs. Maintenance of healthcare service. Yes, in our presentation earlier, we have taken note that other healthcare services are suffering. So we have plans as to how we're going to deal with that. WHO pre-qualified fridges. Yes, Honorable. This is according to the WHO standard, and I think we have to get those ones, because I think it will help us in terms of making sure that the vaccine, once stored in there, would still be of quality and that it will not compromise the outcomes. And this fridges are not readily available in the country, so some of them are ordered from abroad. The need to have hospital oh yes, the next question was the need for us to have hospitals in district or hospitals in the district that would respond to COVID. Yes, and in order for us to avoid sending them to central hospitals. Remember when the plan started, it was in Mangaung. We concentrated in Mangaung. We looked at what was achievable within the shortest space of time, and Universitas and Pilonomi, as well as Bongani and the Tlabeng were facilities that we could have, quick wins, and we dealt with that in that manner. But we also, in our plans, as you have heard me talking about the clusters of infrastructure development, we dealt with that to make sure that every district it's dealt with, or it's covered. Plans on the decommissioning of the field hospital. Yes, we did agree that we don't need this hospital anymore. But as we planned for the hospital, one interesting thing, which was a risk that was identified by my officials, was the fact that we are spending money there. Now, what is it that we're going to do to make sure that when we are audited, we are not found to have spent money which ultimately resulted in an unwanted expenditure? So what we did was we agreed that between 75 and 80% at the most, if we can, of the material that we are putting there should be a material that is reusable. So in other words, your equipment, your HVAC systems, and all that should be reusable. So we are currently in a process of decommissioning, where our infrastructure team, as well as that of public works, are working together with the landlord in making sure that we harness all the material that we can then redistribute to hospitals. I spoke about oxygen tanks that we are already doing. So that is not going to go to waste. Why have you left it to the facilities to decide? Honorable Member, Dr. Kenny, we have said we needed to decentralize this, and we needed to also, with monitoring and guidance, needed to allow facilities to also decide on certain things. And I must say that what they decide does not mean goes. Our team will, from head office, will go and do an assessment. And once we are happy, we'll agree with the CEO. But if we are not, we will definitely, not agree, and we will not implement that. So it is not to say they are now being given all the rights to do as they please, or to the extent that they may even commit some mistakes here and there. Chairperson, I think I have tried to cover everything. Dr. London will then come in just on the 3 questions that I have indicated. Thank you very much.
Hey, Dr. London.
Thank you, Honorable Chairperson. Chair will indicate if it needs be for me to switch on my video. Otherwise, I'll just continue, Honorable Chair.
Just see your face for a short while. Then if you are not able to link up, then you can disconnect. Okay. All right.
Thank you, Honorable Chair. Honorable Chair, I'll be answering on the 3 questions. I think first they are on community healthcare workers, as referred by the HOD. I'll first start with the stipend of community healthcare workers. Just briefly, during the renewal of the contract of the community healthcare workers, we did pick up some of the community healthcare workers who had criminal records, and we needed to then liaise with SAPS to just monitor whether they can still be expunged, so that we are able then to appoint them officially. So we had a couple of community healthcare workers who were delayed in that regard, but all the stipend were paid dating back to the months. I think all the finalized stipend were paid in October. So currently we don't have any community healthcare worker who are currently not being paid. Secondly, there was another question on the absorption. Honorable Chair, I must indicate that there's a national process that is currently unfolding that has been presented to the minister and the NAC meeting, where there are different models of looking at how we need to absorb the community healthcare workers in terms of their payment or model of payment, career pathing, and other things that are related to the program. At this point, all the provinces, I think, of course, with an exception to Gauteng, we are currently then based on standardized model of payment and renewal of community healthcare workers on contract up until that process has been finalized. So as far as the absorption, the province did not absorb, but we have community healthcare workers on the renewal stipend on a contract up until that process has unfolded. In terms of community healthcare workers doing door-to-door, we did took community healthcare workers to do door-to-door in the first wave of the COVID-19. However, in the second wave, when the numbers went down, we then realized that some of the programs, and I think the strategic programs that the community healthcare workers are responsible for in the households were actually starting to suffer. Then we pulled majority of the community healthcare workers to start doing their normal household visit, looking at the other indicators, including COVID-19. So as it stands, we don't have community healthcare workers doing door-to-door, but we do have community testing centers, but we have all our healthcare facilities, whether it's hospitals or clinics, they are currently doing screening and testing. So the communities are aware. We do go to radios just to make sure that they understand this kind of communication, that should they need to test or screen, the facilities, health facilities are open for that. I think another question, it was on Albert Luthuli Clinic, that is in Wesselsbron. Honorable Chair, I must indicate that in the first wave during the month of April and May, we did have some challenges with PPEs, as there was a lot of demand. A lot of countries were procuring, but there was really a demand even within South Africa for the demand. So we, at that time, we actually had some low stock in terms of PPE, in particular to Albert Luthuli. During the month of April and May, we were out of surgical masks for about 3 days. And this was sorted by the district because the district was already in the process of, they've already procured. However, we did also indicate to the municipality of Nala to then assist us in the meantime. So they did by intervening, by supplying the clinic with a shield. That was in that time. However, as it stands, the province, I mean, I'm speaking on behalf of all 5 districts, we currently don't have any challenges with PPE as it stands, because this is part of the weekly monitoring that we do as we monitor the COVID infections in the province. I think the last 2 questions were on the strategic programs that have suffered. I must indicate that in the Free State, the TB program actually did very well in terms of the TB treatment success rate. We actually did very well compared to the previous years. Maybe the COVID really assisted us in ensuring that the clients actually adhered to TB treatment. However, under HIV, we did have some of the indicators that were not doing well, and mainly we had challenges or a drop in terms of the testing. And in the province, we've always been doing well in the number of people that we test each and every year. So we had reduced number of people that came for testing, and this can be attributed to, of course, the reduction in the primary healthcare headcount, but also not only primary healthcare, but also hospitals. So there was a less testing, but also we lost some of the clients that were already initiated on ARV. Due to the closure of majority of the adherence clubs. We had about 1,024 adherence clubs in the province. that are for clients that are on ARV and TB treatment and other, of course, comorbidities. But due to the restrictions of the lockdown and, of course, the numbers that are limited in the rooms, we could not really have this. But we have started with the resuscitation of this adherence lab, which is part of the decanting strategy to ensure that our clients actually adhere to treatment. So we've started that only in the third quarter. But however, there were also some interruption during the December and January month, but we've started with this adherence labs. But we've also then ensured that we reach majority of the clients, those who needs to be tested. We planned to have outreaches in the places of work, in terms of on the mines, correctional service, we do that, but I think now we'll be intensifying it. But we've also introduced a strengthening program, which was not really that hectic in the hospital for screening and for TB and HIV. So these are some of the strategies will ensure that we actually try to reach as many people who did not come to our institution. Of course, the MMC, it was severely affected because all, according to WHO standard, we were told to really hold the MMC. But the plan is that we know that by the end of the financial year, we might not reach the target, but the plan is that we will intensify on the demand creation like we usually do, but of course with the support of the implementing partners. But we'll also then conduct the MMC camps, which is something that we're not really doing, particularly during the school holidays, where we'll actually team up with the Department of Education. We already have a very good relationship to ensure that we actually conduct as many MMC as we can. I think these are the questions that I had to respond to, Honorable Chair. Thank you.
Honorable MEC,
Yeah.
there is one part that our Dr. Tembewayo always asks. She forgot to ask it. She asks it on our behalf. We do already have your number. We got it from the National Department of Health. But however, we still wish to have a reliable number that can get into you without someone ignoring a call, so that honorable members can actually contact you via that number. So you'll give us any comments, a number of a person who is in your office or who could be reliable, can give you messages on our behalf. Lastly, Miss London, Dr. London, we don't know when we are going to get a second, a third, or a fourth wave. The key to the challenges of clubs and people not getting their medication on ARVs is CCMTT. Please strengthen that strategy. Otherwise, we will be found wanting on the third wave again. Honorable MEC.
Thank you, Honorable Chair. Honorable Chair, our parliamentary liaison officer, Ms. Lindy Nkupane, her number, I don't know if I should talk about it now or
yes,
she will send it. Okay, it's 066. It's 065 894 3056. Let me repeat. It's 065 894 3056.
And the name?
I think Lindy Nkupane.
Okay, you can continue.
If that would be if you don't find me, but I think my phones, both of them, I am reliable. You can get me at any time unless I'm in a meeting like today. I think the questions that were asked were all answered except for one where we were asked the availability of water and electricity in some of our facilities. We do experience that from time to time when the municipalities are having problems of water and electricity, but as the department, we do take a responsibility to make sure that our district managers ensure that we take water to our facilities to make sure that we avail water for them. And we work in close contact with our municipalities. We even the Department of COGTA to ensure that we avail water and electricity in our facilities. At some point in one of our facilities where we did not have water for a long time, I know it came through some of our political parties. It was in Virginia where we had a problem. The municipality had a problem. The pipes were not working there, and the pressure that was going to the clinic was very low. but we used our infrastructure people to work with the municipality to ensure that we reinstall the pipes that will ensure that water get the pressure of the water that goes to the clinic. It's enough to make sure that we do have water in the facility. And I must say the multi-sectoral approach that we are using as a department is working for us, because we are able to communicate with any department at all the time. And we understand that the problem of COVID is not just the problem of the department. Even though we are a lead department, we need our sister department to take part and play a role. And the issue of the communication with the communities, I really think HOD answered it well, that we do everything except for our community healthcare workers. We also have our own campaigns, and our communication make sure that they organize the interviews for us. We also have our governance structures helping us, because we have also given them, we do give them information so that they can, as well as our link to the communities, talk to the communities on our behalf on the issues of COVID-19 and other priority programs that we have as the department. Thank you very much, Honorable Chair and Honorable members of the Portfolio Committee on Health.
Okay, honorable members, it does look like our questions were sufficiently answered, unless there's a member who would want to actually raise another point. Any member? Can we release the Department of Health Free State? Okay, Honorable MEC and your team, thank you very much. We have actually sufficiently covered all the processes. Thanks for following up on things that we had learned about your province that were not happening well. One of them is security, EMS, and you seem to have actually adequately replied on that. And thanks for this other information from Dr. Mutao, that you are actually educating and assisting and getting our healthcare workers to to sign a consent before they do the vaccination. With that, honorable members, let us release the team from Free State, but remain behind to finish our work as a portfolio committee.
Thank you very much. Goodbye, honorable members and honorable chair.
Thank you, Chairperson.
Honorable members, let us take this opportunity now to consider the minutes that was going to be an agenda item, the minutes of last week, a visit by the Northwest Department of Health. If Ms. Majalamba can put them on now. It looks like it was a full house. The only apology was that of Honorable Sukers, and your name, just confirm that all your names that do appear there. And it was a detailed presentation. And then Ms. Majalamba, go to the last part where the second bullet of that, go further down, Ms. Majalamba. I take it that the members read these minutes. I'm just interested in those resolutions that we took. There's two that I picked up there. The committee agreed, number two, the committee agreed that it should utilize any other day except for Wednesdays to meet with the minister. I wanted to take that resolution to remind you of that resolution, because there's the next point that I wanted to talk about, which is highlighted there. But any member would like to, having read the minutes, call for adoption of these minutes?
I'm calling for the adoption of the minutes, Chair.
Chair,
may I say something?
Honorable Kwahube calls for adoption. Honorable Kela, seconder. Honorable Ismail wants to say something.
Yes, Chair, just on the resolutions on 5.2, if I can call it that, the committee agreed that it should utilize any other day except for Wednesdays to meet with the minister. Chair, I think we agreed that we shouldn't have the meeting with the minister and the, in a particular province at the same time, but we did agree that we could have it on the same day. So I don't know. I don't know if the reflection is correct here, or did I understand it differently? Please advise.
We have a lot to do. We are saying we have a lot to do on Wednesdays, and the minister comes with the updates of a program that is ongoing. We felt we should not block a Wednesday, maybe to listen to SAPRA or listen to MRC or listen to any other person and get him, because we may still not be able to get him all those Wednesdays, fortnightly, but use any other time available other than a Wednesday for his briefing. That was the spirit of the meeting, and that is how I understood it. Okay. Minutes have been adopted. Yeah. May I then, honorable members, based on that bullet point, invite you and request you that there is an update meeting with the minister at 9 o'clock on Friday. The link will be sent to us. And the minister said though some of his officials may stay until 12, he would probably have to leave at about 11:30, 9 to 11:30 with him. And then the last 30 minutes will remain with one or two of his officials if it is still we have not exhausted. But an invitation will be formally sent to us, and we will then we'll be coming in on a Friday, this coming Friday. Let me also say, honorable members, we will be sending with Ms. Majalamba the other outstanding matters, at least for the next 2 weeks before Parliament rises, take a break, to give you items that we think we must discuss. Some of them were raised by the honorable members here with regards to the agency and the outstanding items. But for now, let us send that to you this evening as to what we'll be handling next week.
Sorry, Chair.
Yes.
I just wanted to, just for clarity, I absolutely agree with your reflection that, look, we should utilize, as you know, any other day that we can for a briefing by the minister, simply because also the situation is constantly fluid. And if we are able to fit in a briefing by him and his team, it's absolutely crucial. And I think we should prioritize it. But obviously, I think, because as you've said, the Wednesdays are jam-packed with other committee work. I just wanted to just get a sense on the agenda for Friday. Are we getting sort of a feedback on where we are in terms of vaccine acquisitions and things related to that? Or is there something else in particular that he wants to address?
Yeah, we wanted to prioritize the vaccine update in provinces, the acquisition, distribution, and the process, and where are we? Other people are concerned, do we get to the 67%, 40 million by what date? Are the projections? But if there's any other item, any other member would like to raise on that spot, we will not stop that. But it is mainly to get a progress report and the update on the vaccine situation in the country. Thanks.
Thank you.
Chairperson.
All right, who's that
Chairperson.
now? Okay, that sounds like Honorable Chirwa. Yes.
Yes. I wanted to find out which date we will be doing the motion of desirability for the national amendment, for the National Health Amendment Bill, under Dr. Susan Tembegwayo, the private member bill, because we haven't done the motion of desirability, and we're about to close on the 19th of March. And we had said it's going to sit through in the first term this year. So I just want to find out when exactly is it planned for. Thank you, Chairperson.
Yeah, we will communicate that this afternoon. I was working with Ms. Machalamba. I was hoping that we have it on the 10th. So our next portfolio meeting on the next week should consider that amendment bill that was brought by Honorable Tembegwayo. Most likely, yeah. Thanks. Okay, honorable members, thank you very much. That brings our meeting to a close. Have a good afternoon and enjoy the rest of the day. We'll see each other again on Friday in the 9 o'clock meeting. Thanks.
Thank you, Chair.
Please, Chair, note on Friday my birthday.
Okay.
Hey, birthday girl.
Start sending us a cake as of now. So
Please. Via
sending the
Zoom.
Send the
Via
cake.
Zoom.
Via Zoom.
I will.
Man, a piece of
Cake
cake.
via Zoom.
Cheesecake,
Okay.
Anna. Bye.